we build, every lab we equip, and every mind we train helps close this gap. The $10 million project is already halfway there, powered by, of course, the generosity of our staff, students, our partners like the Rockefeller Foundation, the US state government, NUFIC, plus, of course, many others. We invite you to join us in investing in the future where knowledge saves lives and where Africa stands strong on its own expertise. Because the future of Africa is its people, and their future depends on public health. Makerere University School of Public Health, building the future of health in Africa.
MakCHs University has been organizing a joint annual scientific health conferences for 18 years now. And this 19th conference is unique because we have partnered with the Ministry of Health to have a concerted effort towards addressing challenges and issues that are affecting the health system, with a particular focus on communicable and non-communicable diseases. As a university, we are critical in research, and we hope that this conference will be instrumental in sharing evidence from our various studies, but also having other stakeholders, including policymakers, NGOs, communities, take part in the discussions, and this will also be instrumental in shaping our future research in health and in health systems. There are several ways one can take part in this conference. First of all, we can have an abstract submitted to present either oral or poster presentations. We can have entities, including departments, projects, and programs, submit to organize particular sessions. These could be workshops, these could be symposia or small events to disseminate findings and to generate discussions around topical issues. We also have an option of exhibiting people's work. It could be scientific products, it could be any other products that could be out there, whether from NGOs or companies. But most importantly, we encourage people to actually plan to attend, and in big numbers. We know that in this conference you'll have different audiences and participants, including policymakers, including researchers. So having people in attendance will enable us to engage with these stakeholders and ensure that questions are asked and answers provided from different people who in a way shape our research, our policies, and our practice in this country.
I would want to welcome everyone to come and join us in this special conference, which combines our 19th JASH conference, which is the Joint Annual Scientific and Health Conference, organized by the College of Health Sciences for the last 20 years. But in a special way, this year we have combined this conference, JASH conference, with the National Communicable and Non-Communicable Diseases Conference with the Ministry of Health. It is special in several ways that we focus on non-communicable diseases, which are rising in the country. Almost many people you find either they have diabetes, they have hypertension, a lot of cancer. So us to focus on these diseases is very important. Again, alongside not forgetting our communicable diseases, the TB and the HIV. It is also special in a way that we are celebrating 100 years of medical training in Uganda, which started here 100 years ago. And we need to highlight this, to look at what we have gained and focus on what we want to gain in the next 100 years. I want to invite all stakeholders in health. You could be a consumer of health, you could be doing business in health, you could be a provider of health or a manager of health. This conference will have something for everyone. For example, if you do business in health, there are opportunities to exhibit to frontline health workers directly so they can know what you do. If you're a policy maker, you're a development partner, you have a chance to interact with the different health professionals, interdisciplinary, one-on-one, during meetings, during breaks, coffees, and after the meetings, so you can understand where your program will look like. If you're a provider of health, you could learn new techniques, new way of doing things. And if you're a consumer of health, which is me and everyone, you could also learn about diseases, how to prevent them. But even if you already have the disease, you learn how to reduce the impact of the disease on you. I would want to call everyone, especially the College of Health Sciences students, lecturers, to come. For the students, we expect your energy, your enthusiasm, and to learn. For the seniors, we call upon you not to neglect this conference and put it down on your list. Please come and attend, guide the young ones in meetings, ask questions, such that we improve the quality of health science that we practice. I also want to call upon the policymakers to come and see how we can be able to translate the evidence that we have generated into impact. Basically, hold us accountable on the evidence that we generate. Is it relevant to you? I look forward to seeing all of you. Thank you.
This will be the new home of the School of Public Health at MakCHs University, the first institute of its kind in sub-Saharan Africa. For more than 70 years, the school has stood at the front lines of Africa's health, training generations of leaders who have fought HIV, Ebola, Marburg, and COVID-19. Their work has saved millions and shaped the future of public health across the continent. But today, our impact has outgrown our walls. We rent scattered spaces, stretching every resource to teach, to research, and to respond to the next crisis. That's why we are building a new purpose-designed home, a place for innovation, collaboration, and training of the next generation of public health leaders, because Africa's future depends on it. Right now, the continent has only 80 public health researchers per 1 million people, compared to a global average of 1,081. This shortfall threatens our collective health security. Every lecture room we build, every lab we equip, and every mind we train helps close this gap. The $10 million project is already halfway there, powered by, of course, the generosity of our staff, students, our partners like the Rockefeller Foundation, the US state government, NUFIC, plus, of course, many others. We invite you to join us in investing in the future where knowledge saves lives and where Africa stands strong on its own expertise. Because the future of Africa is its people, and their future depends on public health. MakCHs University School of Public Health, building the future of health in Africa.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with McChs University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned. We have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of MakCHs University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases.
Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Thank you. You're most welcome to day 2, which again is our second day for the pre-conference. And we thank you for having kept time. As you'll be seeing, according to our agenda, we are supposed to be beginning at 9. And we do not want to lose time because we have quite a lot to cover and discuss today. Once again, my name is Michael Msime from the Ministry of Health. And today I'll be also supported by Dr. Raymond Yaranga, who is here in the house. You can give him a hand clap. And we are going to be hearing from the School of Public Health for the first sessions for today. But before that, I would like to pass on, number one, a few administrative remarks. We are quite a number. We request that you take care of your property as much as you can. Yesterday, we had an incident which we don't want to be repeated today. That's why you see at the entrance, they are checking to make sure everyone is identified. So keep on your tag at all times. And be mindful of your neighbor and make sure you don't leave your bags and your laptops unattended to, much as we have tried to ensure that there is security for all the property. Those of you who have joined us today for the first time, the places of convenience are behind the stage here, but you have to use those 2 exits that are on the left so that you are able to access them. We request the people who are supposed to be presenting by now, your presentations should be ready for uploading so that when we start, we ensure that we keep time. As you can see, we are going to be guided by this agenda that is being displayed for today, and our chair will be joining us after a few remarks that we shall have from the rapporteurs. But the chair of the session is going to be Dr. Alex Ario, who will be taking us through the morning session. We have a number of presenters, as you can see, listed up there. And this is going to take us up to 10:30, where we shall be having our break tea. The break tea is served right at the entrance near the registration table. And after that, we shall come back to complete the session that is ending at lunchtime. So with that, I would like to call upon Alinda Isaac from the School of Public Health. Alinda, you can step forward and you bless our day with an opening prayer. And as he does that, I request the rapporteurs to be preparing their presentation to give us a quick recap in 10 minutes of what transpired yesterday, so that some of you are joining, you can see the key issues that will be guiding our discussion. Alinda, please come and give us an opening prayer.
Good morning, everyone. We're going to have a short prayer. It's going to be in Arabic. Then the last words will be in English. Let's have our thoughts for a prayer. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. الرحمن الرحيم مالك يوم الدين. إياك نعبد وإياك نستعين. اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين. Amen. Most gracious, most loving Father, I want to thank you for the gift of life you've given us this day up to this time. We pray that we be blessed throughout this second day of our pre-conference. We pray that every word you're going to speak, every ideas you're going to share, may they brighten our hearts and even our communities and wherever we are coming from, Father. Amen.
Thank you. And give him a clap. Thank you, Isaac, for that prayer. As the rapporteur has come, we appreciate our key stakeholders that have kept time and the organizing committee. And on a special note, I'd like to recognize Professor Pauline. Thank you for joining us, and we are glad to have you. Colleagues, we also have stakeholders from the districts, the regional referral hospitals with us here today. I can see a number of directors already in the room. Our directors, please, you're most welcome, together with the district leaders that are here and other people. I request the people, Kato, the people managing the registration, we request people to take their seats and we can close the doors so that the members are able to concentrate. And with that, Dr. Mulindwa, you have 10 minutes to take us through the recap as we wait to start the session.
So, Michael, thank you so much. So, yesterday, we had a lot of good work we did, as from the presentations that we all saw. And I'm here on behalf of the team so that I can take you through what we did. And as such, I want to, for those that missed, I want to let you know that in this summary that we have, we'll have the objectives, the themes that we covered, the presentation highlights, the cross-cutting issues that we discussed, the policy or practice recommendations, the innovations or research shared, the notebook quotes, as well as the areas for improvements and suggested follow-up. That said, yesterday, our session was majorly on discussing the ongoing efforts towards integrating, as well as the integrated and person-centered health care in Uganda, as well as to examine the pediatric NCD, particularly the childhood cancers that you saw, as well as sickle cells and asthma. We also explored the community stroke facility as well as policy level responses. And we also used that session to identify the strategic opportunities for strengthening the coordinations as well as, thank you, the coordination as well as the between the Ministry of Health and other stakeholders. In that, we looked at the integration of the communicable diseases and the integration, we looked at the integration of communicable and non-communicable disease services. We looked at pediatric non-communicable diseases, particularly on cancer, asthma, as well as sickle cell disease, the mental health. You remember the session we had yesterday on mental health, the health workforce, as well as the infrastructure gaps that we saw, the digital health and the community engagement, as well as sustainability and the transition in those areas. Later in the day, we engaged with the centers of excellence across the country. We had a very good discussion. However, that discussion is privy to the teams that attended, but we'll just give you a snapshot of what happened in there. Thank you. So, among the things that we discussed yesterday, allow me to use this slide, Dr. Stavia, the Commissioner for Communicable Disease Prevention and Control, explained the rationale for the national service integration to break the program silos that we've been seeing, as well as promote the person-centered care. She argued the mapping of integration. Thank you. Yeah. She urged the mapping of integration across the health facilities, and more so, we also had a presentation from Jinja Regional Referral Hospital, which was shared by Dr. Anna Kavona. She shared the chronic care clinic model, which serves the HIV, TB, diabetes, hypertension, as well as the sickle cell patients that we saw there, achieving a 90.3% score. We also had from Flavia, from Napofano, who spoke about the community lenses on integration, and she noted that we should integrate, not to disintegrate. Remember that quote. And she warned against the eroding existing community HIV structures and called for deliberate inclusion, community contracting, as well as recognition of community health workers. Some of the cross-cutting issues that we discussed yesterday, among them are the workforce shortages, as well as the burnout at health facilities. the drug stockouts, as well as the weak supply chain, coordination between NMS and the partners, the infrastructure limitations, as well as to support the integrated clinics, the fragmented digital systems, the low funding for mental health. We noted that it's less than 1% of the national health budget. That's a call for the policymakers to ensure that there is an increment in that funding for the mental health. We looked at the stigma and limited public awareness around pediatric as well as chronic diseases and the over-centralization of pediatric NCD services, especially in Kampala. And if you remember, there is a colleague from, I think, Bundibujo, if not Kasese, who requested that these services should also be scaled down to those respective facilities across the country. About innovation, we noted that the Jinja Regional Referral Hospital's chronic care clinic model for more disease integration is one of the areas that came out as that we noted as for innovations. We looked at the hydroxyurea and malaria chemo prevention trials for sickle cell disease. That was something very good that was presented. The Treat Interact project for teacher-led mental health promotion. You remember the lady from Ministry of Education and Sports that presented on that. The locally fabricated spaces for pediatric asthma management, as well as the community-based HIV support model sustaining the integration. Like we noted, some of the notable quotes for the day that we think probably you can go along with is one, integration should not lead to disintegration. And in quotes, Flavia quoted that. Integration is everyone's role if we are to promote service delivery. And that was from Dr. Stavia. We can transform a crisis into an opportunity. That is from Dr. Andrew Kambuku. You missed that, but he was able to let us know about that. Mental health improvement starts with me, starts with you. That is from Dr. Hafsa. That is the commissioner for, the assistant commissioner for. Now, the areas for improvement. Yesterday, like I indicated to you, we did some good job, but we still needed us to improve. The time constraints, you realize that because of the time, we had limited discussion, but today the team is prepared to ensure that whatever takes place in time, so that we have good discussions. Some data presentation required clear visualization for non-technical participants. You noted that this conference has brought together a number of stakeholders, not necessarily from the medical fraternity or the health fraternity. And as such, it was noted, I think, from one of the LC5 chairpersons who indicated that at least whatever we present here should also be, in one way or the other, be reduced to the level that other non-health actors are able to understand that. So for the presenters that are coming forward, you should also take that into consideration. The need for stronger linkages between pediatric and adult NCDs discussion. We needed that to come out. It didn't come out well. So in the preceding discussions, this should also be looked at. The suggested follow-ups are to develop a policy on pediatric non-communicable disease integration, as well as convene a multi-sector roundtable. Yesterday we had a roundtable discussion, but this, from the discussion, it had to be expanded so that we can have more other inclusions and participation from others. The published session proceedings into the annual report, we shall be able to provide that. All whatever we're discussing here will be published. And in that publication, like you're going to hear from the team, we'll let you know the modalities of how we're going to do that, so that whatever we've discussed comes and is published across the board and shared elsewhere. We also want to establish an integration learning network for the regional referral hospitals. You realize that the regional referral hospitals are the hub for the integration. So it is important that we establish a network that can support us to do that. So basically, that's what we had from the team. We hope that today we'll still have a very good day. Thank you. Good. So with that said, is there anything that in one or the other we missed that should have been captured from those that attended? Semei, I request, just in case the team is able to move the mic, we can have the mic move around so that we can get the responses from the team here. We're asking just in case there are other areas that you wanted us to include in this summary. We're happy to do that, and would want to, I request Semei to move the mic so that you can be able to take note of what you want us to include. Kato, thank you.
Yeah, thank you very much. My name is Seko Abdul Mutwalib. I am the district chairperson of Uyumbe. From what we discussed yesterday, when you look at treatment and caregiving to sickle cell disease patients, and even at least asthma is okay because in almost all the facilities is there, but sickle cell disease treatment still is not there in the upcountry health facilities. We agreed that there's a need to take the treatment to at least the health center first, including the general hospital, so that at least people in the upcountry areas can easily have access to the medication. Otherwise, if it is in Kampala and other few health facilities, then access becomes a challenge. Then the other concern is also training, building capacities of health workers, knowing that sickle cell now has become a serious burden in Uganda. If Uganda is number 5 in the whole world, then we need to build the capacity of health workers so that they're able to respond to issues of sickle cell disease treatment.
Okay, Chair LC5, you may thank you so much. So colleagues, from what he has said, one, we need to ensure that we capture scaling up of sickle cell treatment to the lower level facilities and most health center force. And then two, we also note that we need to do capacity building across the board. Apologies for that. Yes, Kato. Any other? Okay.
Yeah, thank you so much. Hello.
Please go on.
Yeah, Dr. Ida Nanchinga, JASH Orwirizi. We also realized that childhood cancers are very common, and we agreed that we scale up the capacity building in lower facilities about the diagnosis and management of childhood cancers. Thank you so much.
DHO, thank you so much. The team has captured that. Kato? Okay, from their side and the other side.
Thank you very much. For me, I will quote the Deputy IGG. She asked a question and it had a follow-up to it. She asked, who does the mental health for you health workers? And an analysis showed that I think only 20 districts had mental health focal persons, and it was, I think, advised that all districts, because it's already in the law, should go back and ensure that they get mental health focal persons. Thank you.
Okay, thank you so much. The team has captured that too. You realize yesterday mental health was an issue, and we also heard from the lawyers from the law side how they perceive mental health, and they also indicated in addition to that that they will be willing to support us to ensure that we promote mental health. Please go on.
Relatedly, thank you. About mental health, last night or yesterday, we realized that there are some districts that don't have these focal persons in mental health. And as districts, we are always budget constraint. And you find that, yes, it's provided for in the law, but when it comes to issues of recruitment, we shall look at the budget. And if the budget doesn't, for example, provide for such, we always prioritize the critical health workers that are important in our health facilities. So it's a call to the Ministry of Health that this mental health issue be prioritized straight from the ministry, so that when they send us IPFs at district level, we can provide for recruitment of such critical health workers in relation to mental health. Thank you.
Okay, so that is human resources for health, and more so we need to strengthen that by ensuring that we recruit those staff that can help us with mental health. That is from the health facilities and also in schools. Please go on.
Thank you very much. This is Invi from Vuma. There was a suggestion yesterday that general hospitals, health center FOS, and regional referral hospitals be center for treatment of sickle cells in Uganda.
Okay, thank you so much. I think that is the same that the LC5 Yumbe had emphasized. And like we said, we've captured that and we'll include it in our report.
Thank you, Edward Were from Ginger. There was an innovation of a tool that was used in screening for alcohol and drug use among children. This is one of the key innovations that possibly is not out there in use, in practice. So it being captured among the things that the center needs to take on to ensure this is rolled out is one key take home. Thank you.
Okay, thank you, Edward. The team has captured that and will ensure that it sounds clearly. Any other? Colleagues, we're looking at anything that you think we could have missed in the summaries we've made, the key highlights of yesterday, and more so, the areas that you think should come out prominently in our report or the summaries. Okay, thank you. So Kato, there is another hand this side. Thank you.
Yeah, thank you very much. My name is Nathan Okiror from Baylor Foundation, Uganda. I sit in Tororo. There was, maybe I could have missed it, but what Dr. Nampiji, I think, the pediatrician was talking about yesterday, the emphasis on school health, especially empowering the school nurses to be able to detect, especially asthma and the other communicable, infectious diseases, so that, because most times in the districts, when there's capacity building, or most of these nurses are left out. And we thought that they spent much of the time with the children, and there should be deliberate effort by the districts to make sure that they are brought on board, and they should be supervising physicians to make sure that the nurses have the requisite skills to identify promptly and make referrals. That also came out yesterday. Thank you, Dr. Mulindwa.
Okay, thank you so much, Okino. So in addition to that, we noted that, Dr. Nampiji noted that it's important that we use the appropriate medicines other than us mixing them up to look at the available concoctions, in quotes. And she noted that we have the sabas that we can use. We also have the summers that we can use. And at the same time, she also emphasized that with aminophrine, it is readily available, but it's not what we would wish to use for the treatment. So when it comes to the clinical service, it's important that when we probably reviewing our guidelines, that should still be able to come out because it's science that is informing the prescriptions or the landing. Thank you. Any other? For those that have just come in, we're looking at the recap for yesterday. Just in case you remember what we discussed yesterday or what was presented yesterday that you feel should come out to be pronounced more, please kindly raise the hand so that we can have that noted. Okay, so thank you. So at this time, I want to invite Dr. Raymond. I want to hand it over to Dr. Raymond, but from our side, I want to thank you so much for your participation yesterday. We do believe that your active participation yesterday and today will also be recorded and not taken for granted. Dr. Raymond?
Thank you. Thank you very much, Dr. Alex Mlindwa. Please, a round of applause for our rapporteurs. In terms of the discussions that happened yesterday, those who are not around, I think, can now pick up a picture of what happened. We want to apologize. This morning, we thought we had a panel team, but they are not yet ready. So we want to call upon one of our good friends that have held our hands and taken us for the time in diagnostics, and that is Safeid, to make a presentation, and there will be some questions and answers if you have. They are the people who have been innovatively managed the GeneXpert machine, and they have worked with us for more than 10 years. Actually, they're coming to about 15 years since 2010. So we want to appreciate their close working relationship. So over to you, Job. Job, if you can come and make your presentation. This presentation will take us up to about 10 o'clock, 10:15. We shall break up for a cup of tea, and then we'll organize ourselves and see the next presentations that will be coming on. Thank you very much. Thanks again for all being here. I'm Dr. Raymond Biaranga. I work with the Ministry of Health. I will be facilitating the next presentations for this day. Thank you. Has the IT got the presentation? I also call upon the programs team, please, the scientific programs team, please, let's meet behind to discuss how we move forward. Thank you. A few seconds and the presentation will be on top, and Job will come and take us through the presentation. Job, thank you very much for coming in. As usual, the GeneXpert often comes in to save the day. So, Safed, we want to appreciate your readiness.
morning, everyone. All protocols observed. My name is Job Ndege. I'm the Regional Director for East Africa for SafeAid. And it's a pleasure to be here to interact with all of you from the health fraternity in Uganda and any other friends that we have come here to be with you as you mark this conference. So I'm going to talk about innovation from a SafeAid perspective. I know oftentimes we as diagnostic partners with yourselves give you diagnostic solutions. And the question you get asked is, we have this solution from you. We have been partnering with you since 2011, 2012. What happens in future to the solutions that you already have? Are you future-proofing the infrastructure and the instruments that we have so that should there be good things coming in the health space, we are ready? Thank you. So that's a question that we get asked as diagnostic partners. So as SafeAid, innovation is one of our key values. And we often say that we are going to innovate so that we keep up with the changing landscapes, be it in the public health or the private health space. And one of the key innovation, and one of the key assets that any of you could have from a SafeAid perspective is our gene expert equipment. I know as Uganda, you get support from some of the donors to buy this equipment. You also as a government do buy some equipment and some other private entities in the country. So the 10-color technology that SafeAid has is the newest generation of instrument that you can use for diagnostics. Then the question is, we have been having 6-color technology in Uganda in the past 10 or so years. What happens to that? So to tell us what happens to our existing technology and how it is that we are geared up for the future, we have this 4-point agenda. We'll talk about what types of gene expert instruments we have, and then what is it that the 10-color brings to us, the benefit of the 10-color, and what happens if you want 10-color and you're having the legacy 6-color systems. Okay, so these are the two kinds of gene experts in current production and actually in the field in Uganda. So we have the legacy gene expert. It could be a 4-4, 4-door, 4-2, 2-door, could be a 16-16, 16-door, or a 16-8, which is 8-door. 6-color technology, which is on the left of your screen, or 10-color technology to the right of your screen. And you can see there is some subtle difference. The 6-color one doesn't have any blue bar. The 10-color one is actually denoted by a strip. So why did SafeAid decide to move to 10-color technology? We know that as time moves, the demands of testing requires even more targeting. We need to target even more pathogens. We need to have multiplexing so that we can actually be able to detect either more accurately or we can detect a large range of diseases from one test. So moving from 6-color to 10-color enables SafeAid to be able to do that very easily using the same instrument and technology that you had. As we move to the future, there'll be more demands for multiplexing. There'll be more demands for even better targeting. And what better thing can SafeAid do to the public health space than also moving to the future and looking ahead? We are looking in future of panels. We are looking in future of even disease mutations, which happen more quickly than it is now. And we are saying as SafeAid, let's innovate so that we catch you. And that's why we have the 10-color instruments. But the challenge is, how then do you put 10-color instruments in a situation where you already have 6-color instruments? Uganda is a good case. There are over 380 plus gene experts in the field. Out of those, probably 280 are 6-color systems. The other 90 also are 10-color systems. And we have just said 10-color is the future. Then what happens? So several scenarios. For instance, one, on a site that you have a 6-color, you can add in a 10-color. Buy a full 10-color system, place it with its entire peripherals, computer, connectivity, and the rest, and you have 2 at that site. Of course, you're all saying that's ridiculous. Why will I be having 2 equipment if I didn't need them? Assuming the capacity I had was only for 4. So that's one challenge that we're having. However, from our innovation labs, we came up with a method in which, using your existing instrument, which is 6-color, you can actually co-host 10-color modules and 6-color modules on the same platform. Wow, now that starts becoming interesting. So what has Cepheid done? A 2011 technology is being fused with a 2030 technology right at your desk. Very innovative. So what are we saying? How do you do this? For all the instruments that we are having, be they GeneXpert 4 tools, 2 modules, be they GeneXpert tools, 2 modules, I know Uganda has 2 modules as well, be they GeneXpert 16s, whether they're 8 or 16 modules, you can, at your site, on your desk, have a mixture of both 6-color and 10-color modules on those systems. So what happens? So this is a typical representation where we can have, if your site had full configuration, in the sense that you needed all your 4 modules, your 4 door machines, and you wanted to add, well, you can daisy chain. That's an option. But we are saying, why do we need to do that? Remember, if you go back a bit, I've said we have the capability of having on the same module, on the same GeneXpert instrument, both a 6-color machine, a 6-color module, and a 10-color module. I've also said that if you still need capacity and you're having a 6-color module machine, you can actually add in the newer 10-color machines. But if all we need is to future-proof our systems, then there's a possibility of, in the same machine, converting some of the 4 of the 6-color machines, or the 6-color modules, to 10-color modules. That is what we call the hybrid. So what does this hybrid entail? One, you can hybrid them by having 2 systems running together on one machine. You can hybrid them by having one system having different modules, both the 6-color and the 10-color. Or you can actually convert all the 6-color modules to the 10-color modules. Of course, there are some requirements for us to do this. We need to have the right software on those machines, and the software that we are looking at currently is Windows 10 or higher. Then we as Cepheid, we are going to give you an operating system we call our DX system, which we require to be 6.5. So our teams can do that. But then as we move ahead, how do we also future-proof ourselves against the changing Microsoft Windows operating system? We are saying that moving to the Windows IoT LTSC, we guarantee ourselves support till the year 2031 for Windows. So in a nutshell, you have your GeneXpert 4, 2, GeneXpert 2, GeneXpert 16 with 6-color modules, Windows 10. With a program that we are running with the ministry, we are able to do what we are calling hybridization. And how do we hybridize? We upgrade those modules on failure. So what happens in Uganda is that if a site goes down because of a module issue, and that site had a 6-color module, Our team will go to site and replace it, not with a 6-color module, but with a 10-color module. And what does that mean to Uganda? It means, based on the rate of failures that we're having, your 390 plus systems, maybe in the next 2 or so years, will all be having 10-color modules from that program itself. And that shows the partnership that SafeAid and the Ministry of Health in Uganda has. And remember, for us to move to the future, panels, multiplexing, targeting. I know Uganda is interested in having universal DST on the MTB XDR assay. That assay can only run on a 10-color system. And whereas maybe in the past, Uganda was looking at having some hubs where, just like you are doing currently with your DST system, where you take samples from a site, maybe to a centralized lab, and you start doing a DST. With the 10-color system, this DST can actually be achieved right at the sites from your healthcare level 4s, districts, referrals, where you have a gene expert, which SafeAid has upgraded on failure to a hybrid gene expert, having both 6-color and 10-color, or to gene experts that are all having 10-color systems. So, to finish, is to say that the investment that the Ministry of Health, the partners, the donors, SafeAid has taken in Uganda since 2011 is very safe. We can confidently say that you'll be running those machines as SafeAid innovates with more tests, as SafeAid innovates with more panels, as SafeAid innovates with more targeted assays till 2031, very, very effortlessly, because we are working with you to upgrade them on the field from 6-color systems to 10-color systems. Thank you so much.
Once again, a round of applause for our brother and indeed a man that has actually been able to help us in quite a number of diagnostic areas. We will have a quick question and answer session. I don't know whether there are any quick questions or comments. I know in the house we have directors of hospitals, we have our Vice Chancellor Mbarara University, and we have a number of LC5 chairpersons. Maybe you would be wanting to ask how you can acquire some of these for all your health centers. So over to you, colleagues, if you have any questions or comments. Kato? Here? Here. Thank you. To the Commissioner. You didn't have breakfast, young man?
Yeah, thank you, moderator, and my colleague for the presentation. I'm Dr. Charles Oyo, the Commissioner for NCD Prevention and Control. I got very much interested in your presentation, and especially in the line of NCD. So you fell sort of talking about HPV testing.
HPV, okay.
Just talked of MDR, and yet we are talking about integration. Then two, we are here with very many people from non-medical background, from non-laboratory background. So all that you presented in a simple term, what is the take-home message?
Okay.
Thank you.
Very good. Comment or question? Any other comment or question? Yes, here. So can the gene expert do more than just the NPR?
Yes.
Thank you so much. I'm called Asimwe Kalemire and I'm a field service specialist who supports the gene expert machines in Eastern Uganda. Since we talked of integration, I would love to draw to yesterday's discussion. I want to bring an experience from the field. We have these gene expert instruments in our hospitals, and we find that the supplies are there, the instruments are there, but key in point I want to talk about HIV viral load. So there is a facility that I visited, and there were HIV viral load kits or test kits in the lab, but however, the clinicians were not requesting for an HIV viral load test. So when we went through an engagement, we discovered that we had partners or IPs who had staff that were supporting to request or ask for viral load tests from the laboratory. But since we all know what is happening, these staff have either been laid down or downsized. So they told us that the people who are requesting for these tests, unfortunately, are not working, and we are overwhelmed with work. So I would love to request all the DHOs, all the leadership and management of these institutions to kindly help support the people at OPD, the clinicians, so that they are able to send these requests to the labs because the test kits are there. However, we are always grateful to support you, and we are so much available to have the tests go on. Thank you so much.
Thank you, Kalemire. So some more information will be given by Job, especially on the responsibilities of our field teams, what they are doing and how they can support making sure that the uptime for these machines continues. Any other quick comment or question? So probably, Job, you could go through those two.
Thanks, Dr. Raymond, and thanks, Commissioner, for your good question. So let me go back to the instrument. I picked it from the innovation part. So the Gene Expert instrument at the moment supports at least 31 CE IVD marked tests. With that same instrument you're having in your 389 facilities, you can run 31 CE IVD tests, all the way from infectious diseases like Ebola, Mpox, TB, to oncology like BCR-ABL, breast cancer, HPV, like the Commission was asking, hepatitis, sexual health, CTNG, virology, HIV, virology as well, HIV viral load, HIV QA for qualitative. We are talking of other sexual health. I've mentioned the HPV, CTNG, TV, and a host of other tests. So the current system, 6 color, whichever year you bought your equipment, can run all these 31 tests. The only test that the current 6 color system cannot run is the MTB XDR. That's why I brought it as a highlight. For you to run the MTB XDR, you need the 10 color. And it is taking that message for 10 color and knowing what's safe from the requirements of public health burdens that we know happens, newer panels that are a requirement in the various spaces, be it in the gastro field, be it in the, any other field, for instance, will require us to multiplex more, will require us to target more. So whereas we have started the 10 color with XTB, with the MTB XDR, it does not mean that that's the end of that innovation. It means that should we come with newer testing requirements, then your 10 color innovation will still support you. So all the 6 color machines currently running can run 31 tests, like I've mentioned, across that spectrum. However, for you to run MTB XDR, you need the 10 color system. And it is with that knowledge that CEPHAID has worked with the Ministry of Health in Uganda to ensure that if any of the sites you are having has a failure in the module, and if that module is 6 color, then you are replacing it with a 10 color. That means all your sites will now be able to run the XDR in addition to the other 31 tests, plus any newer assays that will come up with that requires high multiplexing and high targeting. In summary, to the audience that Commissioner Dr. Charles has asked, what does this mean to all of us? It means the 5 high disease burdens that Uganda has been classified as with the WHO, from TB, HIV, associated the pandemics, Ebola, Mpox, and the other associated diseases like CTNG, which actually sometimes co-host with the other 2 diseases I've mentioned. Your investment in the gene expert is enabling you to very accurately, on time, at the point of sight, when a patient comes, within less than 90 minutes, get a result because you already have the system. Gone are those days when I, as a patient in Uganda, I go to a health facility, my samples are taken for a test, I'm told I need to wait for 10 days or 14 days to get my test. With the investment Uganda has in the gene expert, those diseases that require immediate attention clinically, and that clinical attention requires accurate diagnostics. With the gene expert on site, I'm telling you, you are home and dry, because in less than 90 minutes, we are going to tell you whether you have that particular ailment or you don't. And going forward then, because you already have this on site, we are going to ensure that that investment that the Uganda taxpayer has already put in with CEPHAID since 2011 is guarded till 2031 with all the things that we are talking about here. We won't need to buy a new equipment because CEPHAID has developed something else. As long as we have the windows set up nicely with the LTSC, and we have the CEPHAID 10 module on your system. Commissioner, I think that's a summary of what you had asked.
So you can see already what the potential that we have in our facilities. And I do believe and I know that every district in this country at least has a gene expert machine or 2. So there is a lot of potential that we have in our districts in managing our patients better and diagnosing our patients better. You've heard of the cancers. Now we can be able to diagnose cancer of the breast.
Yes.
What are the other cancers?
Leukemia.
The leukemias.
Thrombosis. Factor 2, factor 5 as thrombosis, leukemia, breast
cancer, and the others. So
NPM.
So all we need is making sure that we have the cartridges.
Correct.
For those. Currently, I think we have more or less the viral load cartridges and the TB cartridges.
Correct.
But
TB,
the machines,
viral load, and the qual. And HPV.
And HPV.
Those ones are within the facilities at the moment.
So others are not yet there. So we need, but again, it calls upon our health system to be able to be alert and be able to pick up even the Ebola. You say the Ebola.
Even Ebola.
So even the
Mpox.
The cartridges for Ebola.
COVID.
COVID-19, Mpox. So you can see, colleagues, there's a lot that we have in our, all we need is to make sure that we have both the resources, but also our health workers are able to quickly, screen and know what to be able to do to be able to provide this service. What we can also add quickly is that these machines are maintained by the SAFAID team, and we usually add a small top-up, especially on our cartridges, to keep them maintained. All we need to make sure is that the way they are maintained, we need to report as quickly as possible so that the maintenance can, can stand the test of time up to 2031.
Yes, Dr. Raymond, and that's one of the innovations that the Ministry of Health Uganda and SAFAID have worked into. Before, it was a bit difficult on how do you get service level agreements for such equipment. A few years ago, Uganda came up with this issue of surcharge, whereby we agree to maintain all your systems, but we add a small fee on the assays as you buy them. So we don't put pressure on Uganda to pay us money upfront to do that. But as Uganda procures, we get something that we can use to provide those service levels. And because Uganda is a big country in terms of support, it could be not very big geographically, but in terms of support, it's a very big country. SAFAID decided to decentralize our support. So we have engineers and application specialists in each of currently the 5 regions in Uganda. I'm including Kampala as a region, so that our support is quicker. You don't have to have someone come from Kampala to Arua for us to support you, because we have somebody covering where Arua is, you have somebody covering where the other regions are, and they're with you. And other than when we have an issue, or which we call corrective, the teams are geared in a manner to prevent issues happening. So we also have a set of preventive actions that our teams take. So that also ensures that you have availability, because there's no point of having a system and out of 4 modules, 2 are down because we can't support it, or 1 is down. So we want to ensure that your machines are available so that you can test as and where is needed. And to ensure that this maintenance is done within supported and agreed upon levels, we have a routine where every month from our end, we send reports on what it is that we have seen and what we have acted on from a service perspective. And the ministry also does likewise. And we have a meeting, typically the first Friday of the following month, where we compare notes and check, did SAFAID meet and beat its commitments for service? And did the ministry also check and meet the requirements to enable SAFAID to meet its service? So this ensures there's two-way communications and such that we don't assume that things are moving and they're not moving. And at the same time, these teams on the field, should you have any need at your facility or at your district for some on-site training, for some improved application support, you want to add in a new disease. You have heard that currently in the country we have TB, normal TB XDR, HPV, and HIV-VL and HIV-QA kits. And should you have a facility that requires this, you don't have to wait for one big training sometimes in the future. Our field person can come to site, train both your clinical and lab teams on how it is. So we are in such a way that we want to work with you right at site. And of course, that collaboration also moves to the national level, where oftentimes with the program, all the way from the highest levels, we also engage to ensure that we keep abreast of what it is that you need as a country and how it is that we can respond.
Okay, yeah. Thank you very much, Joe. Any other quick comments or questions to bring this session to an end. We want to take a cup of coffee. Okay, yes. Alan?
Yeah, thank you very much. And thank you very much for this session. Thank you, Dr. Raymond and the presenter. I'm thinking about this very beautiful session that we are having and how beneficial it is for us as community advocates. Because with all this technology in place, for as long as the demand is low, then there will be underutilization. Mine goes to the ministry, not necessarily to the presenter. How ready are we in terms of passing on this information? And what is the deliberate collaboration strategy with community experts to ensure that this information flows down? And then, Dr. Raymond, are these services available in our mobile trucks? Because then there is need for vigorous community mobilization. Otherwise, if people do not know, then they will not be able to demand for the service. And then secondly, when you go down to the districts, without being particular, issues of equipment maintenance. I think what is being echoed down there is, yes, the maintenance happens, but the delays. There are a lot of delays, and maybe we need to find ways of getting some quick responses on that, and ministry paying attention to it. Otherwise, those delays end up costing us lives and maybe delayed initiation on treatment and other tests that are required. Thank you.
Thank you very much. That is the voice from the community. We need to increase our support to making sure that demand creation is done. Thank you. Next, yes.
Good morning, ladies and gentlemen.
Good morning.
Once again, I'm Collins Joshua Kabogoza. I am a Master of Science student biomedical engineering at Mbarara University. Now, I wish to thank you, Mr. Job, for this wonderful presentation. I am a biomedical engineer, so I feel happy when I see such equipment in circulation. And much as we are trying to push this innovation issue at our end in Uganda, some of them we are not at a level of manufacturing them, and having companies like yours try to push this to our society is really impressive. Meanwhile, I thought I couldn't say this, at any other moment, but talk about maintenance, because we started yesterday, but no one has talked about maintenance of medical devices. And probably to maybe add on what she has been talking about it, we have challenges. We as biomedical engineers, we want to work, we want to do this maintenance in all these hospitals, but then I believe there are some programs probably the Ministry of Health could put in place to support our work. For example, I have been volunteering for as long as I remember. I don't have a job anywhere. I am volunteering hospital to hospital, Kawempe to Jinja to Kamuli to wherever I can get my hands on equipment. And genuinely, I have done some good work. But a program like, for example, an internship program where volunteers are paid or given some allowance could really boost up this issue, because we have a lot of biomedical engineering graduates out there not doing anything because they are like, okay, Ministry of Health doesn't have jobs for us. And recently there was an advert where they wanted only one biomedical engineer, and it was around 68 of us applied. Another one from Public Health, Public Service Commission, 88 applied. They wanted one person. So this is something I would like to advise the Ministry of Health. For example, maybe if there are no jobs yet, we could have volunteering programs where volunteers can be given some allowance. I've never gotten anything, So that's what I wanted to say. Thank you very much for listening, and thank you very much for the conference.
Thank you. Thank you very much for that polite, honest request. And indeed, I think your yeah, we need to look beyond just the machines. The surveys should start also looking at how they support the local population in terms of the biomedical engineers. One interesting thing that I know is that there is, among the engineers that they have that are looking at this equipment, none is a foreigner. They are all Ugandan born, and I do believe I know there are few because we are looking at, he has mentioned the 5 regions, but we have more regions, so we really need to see how we increase on that support. But information taken as the Ministry of Health, and we look forward to seeing some of these recommendations presented during the conference where the minister will be to push this. Do you have any last quick comment?
Yes.
Hold
And
on.
No, hold on.
okay.
Yes.
Good
Oh,
morning,
yes.
good morning. I have the mic first.
Oh, yes.
Thank you.
Flavius, sorry. You know when you are seated and the
And
mic
I'm
is down,
short, I need to
you're short,
buy,
I can't see you, but
I need to buy Ambi so that I even be brown.
it's okay. Please go
Thank you
ahead.
so much. Good morning, and thank you very much for that good presentation. And I'm Flavia from the National Forum of People Living with HIV, and I also sit on the Global Fund Country Coordinating Mechanism Board. I also represent African patients on the International Alliance of Patients Organizations. So for me, diagnostic safety is very, very important. And the reduced time for getting results helps even get the right results. But many times we would go, you give your specimen, and then you are called after 2 days to come, and because something happened along the way. So that is a very good initiative, but also to allude to what Alan has said, when we do site visits, we do realize that a number of equipment, not only for the gene experts, is stacked in boxes because we don't have people to even install them, to maintain them, to manage them. So we hope this is not one of those cases that you add on other levels of expertise, and we don't have the right expertise to manage, or which is not even trained to manage the innovation. So as communities, we are happy, and we believe that when that is there, we continue to commit to mobilize more for TB. Those of us who have suffered TB know how it hurts, but we also know what it means to have TB and you don't have a result in the next 2 days, or but 90 minutes is really awesome. We would love to see that across the country. Thank you.
By the way, including viral load now.
Ooh.
Yes.
Oh,
So
that's nice.
we are taking care of them.
Does my Center of Excellence have that 10 stage, so that I go and get my results? I was bled 2 weeks ago. I need to get my result.
Please.
Thank you.
Yeah.
Hopefully they do.
They do. They do. They do. If they don't have, they are, I don't know when they started, 1900. We shall get there.
They do, yes.
Yeah, the final mic is with me here.
Oh, okay. And then our colleague behind there.
Thank you so much, our moderator. I was not going to speak, but my colleague here tickled my mind. These engineers of ours, we are training and not giving them, directing them what to do, and supporting them. It's really touching, and I would like to suggest that we need to have a very quick action on this. The PSC, the minister is not with us, but this is a field I think we have really neglected as a country. And we have lost a lot of equipments. They are there, sleeping. There's no good action. What really disorganized my mind is when I went to Mulago Referral Hospital. I had my girl for testing MRI. The machine is there, very new almost, but not functional. Then they referred me to private, and they asked me 800,000 shillings to get that service, and I didn't have the money. I was wondering, I talked to the attendant, what is the problem with this machine? He told me just a few things, something like reagents, what he needs to use. He has requested for months and months, no response. But of course, the private facility is in the Mulago Public National Referral Hospital, where they are just pointing that you go there. Is it really logical for our country? These experts here we are grooming, they are just roaming, as he's telling you, Kawempe, Jinja, no even allowance. I think this need action in bold. Let's support these young engineers, even not send them abroad that they can repair these equipments we buy abroad. That is the best way to sustain as a country. Thank you.
Okay, thank you. That has been well documented by the rapporteurs, and we shall have an aid memoir at the end so that we can follow up these recommendations. Last.
Thank you very much. My name is Lamu Edet from Tororo. I would also like to add my voice on top of my colleagues to thank the presenter for the job well done. The other thing is that as far as GeneXpert is concerned, Tororo as a district, we are also a beneficiary, which is very good. And the other thing I've picked from the presenter is that they are also trying to address issues of turnaround time, which is okay, because it is one of the things we have been struggling with. But in Tororo's case, there's something that keeps bothering us. One of our 4-module GeneXpert machines does not have a power backup. In a way, it takes us back to extending the turnaround time. Because right now, we are experiencing unstable power. So you realize that whenever cartridges are loaded, ready for running the tests, when power blacks out, all those cartridges get aborted. So we are registering a high cartridge wastage. My issue here is what plan is there for us to get a power backup for this machine? Because it is placed far away in one of the health center force, in a health sub-district, which we feel if it gets a power backup, it will lessen us the issues of hub riders running long distances. I beg to move. Thank you.
Thank you very much. I think the challenges of electricity, the challenges of infrastructure in terms of our labs, but also the roads, turnaround time is always affected, and we get a lot of errors. Something that the Ministry of Health is working around with partners to see we can quickly answer the issue around, especially backups. I want also to quickly assure Alan that the mobile vans that we have all have GeneXpert machines in them, and that also tends to increase the turnaround time for diagnosis of TB, but also once cartridges become available for the other conditions, then it will also make sure that the community is well served when it comes to those other conditions like the malignancies and the viral load that we'll have. I just want to end this discussion here, just a parting shot from Job, and then we'll take a break.
Thank you, Dr. Raymond, team, for good comments and good questions. I'd like to address one issue of localization. Like Dr. Raymond has said, we have 5 persons in Uganda. They are all Ugandans. I'm from Kenya, but I'm a Ugandan because I just come from across Lake Victoria. We all came from Sudan with many of the Ugandan communities, so I'm Ugandan as well. But the bigger thing is that whereas CEFED is an international company, and we have a partnership which we call the High burden disease countries, where Uganda is one of them, where we offer tests at very affordable prices, in fact, at no margin to Cepheid. We decided, for the sake of localization, to have a partner in Uganda. We have a partner called Science-Scope Africa. That partner can also access our cartridges at the same high burden disease market access program for the ministry. So if you want to grow your local people and you want to buy through your partner, that's still okay. If you want to buy directly from Cepheid, that's okay. The idea is that we want to help you end TB by 2030, HIV by 2030, and all these other diseases, human papilloma virus, hepatitis, CTNG, and the rest, by ensuring that we give you diagnostic capacity that's accurate and in a timely manner, and also develop your local skills so that we can have sustainability. Thank you very much.
Thank you. Thank you very much, Job. Another round of applause for Job. Thank you very much. We are going to take a cup of tea. When we come back in about 25 minutes, we shall get very interesting thoughts, presentations, discussions from both our directors of the, I still call you directors of regional referral hospitals, others call you consultant, executive secretary, others presidents, others. So anyway, we'll see that. So we'll hear from the regional referral hospitals on how the integration is going on. We shall also get some tips and points from the districts, the DHOs that are here, to take us also through how is integration ongoing in the district and at facility level. So please get back early so that we can get these interesting thoughts, and your ideas are also welcome in terms of how we can improve or continuously engage on making sure integration of services at facility level goes on. Thank you very much for being a very good audience, and see you at 10 minutes to 11. Have a nice cup of break tea. Thank you.
Father in heaven, we give you glory and honor. We bless your name. We acknowledge that this is the day you have made for the annual conference for the communicable and non-communicable diseases.
We are going direct into business in this pre-conference, and we have a number of organizations that will be leading us in the pre-conference.
You've already been welcomed to today's conference, and we are privileged as the Uganda Pediatrics Association to set the stage and kick off the conference.
We encourage our patients who have asthma to have daily inhaled corticosteroids as the mainstay of treatment, other than using salbutamol whenever they need, because continuous use of salbutamol is associated with hyper-responsiveness, or your chest responds worse, what people call addictive to the drug.
In order for us to address, everyone needs to know what sickle cell disease is, how it is transmitted, who is at risk of getting it, not when they have grown and they're going for premarital counseling. It's too late.
Many children are actually not looked after by their own parents. They're looked after by guardians. And I know there's still a little handling that.
Richard, we appreciate that actually the half-life of dihydromethamphepaquine phosphate, DP you mentioned, is about 42 days. But I note you are giving it weekly in sickle cell disease. What would be the sequela of prolonged use of DP, given that actually it's given weekly compared to its half-life of 42 days?
Do you think
children with asthma, it's okay to engage in all these kind of activities.
Ministry of Health, we really need to up our game and ensure that we have these screening kits for sickle cell at the NMS and they reach to all government facilities. Thank you.
Out of this conference, what are we saying we can do next year, beginning January, to make sure that our communities are saved from some of these probably easy to solve problems? Thank you.
I used to think that asthma and sickle cell diseases are not treatable. I'm just getting to learn from the presentations here that we can treat these diseases.
Epidemiology of childhood conditions has evolved over time, just as we had one of our oncologists talking about how the cancer epidemiology has evolved. So people who trained a long time ago may not be very aware of the distribution of childhood illnesses of date, but also more information is out there. Research is being done and there's more new knowledge. So the in-service training alone is not enough. The pre-service training. We need to do more in-service training as well to continue to improve the knowledge, continuous professional development of our doctors, both in the tertiary setting, but also in the primary care level, to give them this new knowledge so that as children come, they are better equipped to diagnose them, to suspect, diagnose them, refer them or manage them with the new knowledge and the new capacity, the new skills, the new instruments that are out there now.
Sickle cell disease in the country, about 20 to 30,000 babies born every year with the disease, and Uganda has number 5 with the biggest number of sickle cell disease worldwide. So we need to work together, Ministry of Health and other partners, to address sickle cell disease and other non-communicable diseases. And I suggest that capacity building is built not only for health professionals, but for everyone, so that we can sensitize the community and also provide good services for the patients.
JASH conference is actually an excellent platform because it brings together different stakeholders, not just from the clinical field, but also from civil society and other supportive fields in medicine. And why is this very important for pediatrics is because taking care of a child, like traditionally we say it takes a village to raise a child, but it takes the same village to actually take care of childhood medical conditions. And I'm excited that the Uganda Pediatrics Association was invited to this conference, and we kick-started it because children clearly are our future, and we got a chance to shed light on the burden of NCDs in children and some of the commonly mismanaged or not very well-managed conditions in children. So this has been a great platform for us, and we hope that every year we'll continue to share and raise more awareness. Traditionally, childhood illnesses have been reduced to just acute illnesses, cough, flu, pneumonia, malaria, but that is even just a tip of the iceberg. Childhood illnesses are broader than that. And today, really sharing on NCDs in children, whatever we touched on was just a little bit, but children suffer from any other chronic conditions that adults may suffer from. Things like diabetes, developmental abnormalities, other endocrine abnormalities that affect children. And we hope that with time we'll continue to spread more awareness. But this was actually a very great platform for us to begin to raise this awareness and build capacity.
conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the Makerere University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of Makerere University and especially jointly with the Ministry of Health, because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
Makerere scientific health conferences for 18 years now,
And this 19th conference is unique because we have partnered with the Ministry of Health to have a concerted effort towards addressing challenges and issues that are affecting the health system, with a particular focus on communicable and non-communicable diseases. As a university, we are critical in research, and we hope that this conference will be instrumental in sharing evidence from our various studies, but also having other stakeholders, including policymakers, NGOs, communities, take part in the discussions, and this will also be instrumental in shaping our future research in health and in health systems. There are several ways one can take part in this conference. First of all, we can have abstracts submitted to present either oral or poster presentations. We can have entities, including departments, projects, and programs, submit to organize particular sessions. These could be workshops, these could be symposia or small events to disseminate findings and to generate discussions around topical issues. We also have an option of exhibiting people's work. It could be scientific products, it could be any other products that could be out there, whether from NGOs or companies. But most importantly, we encourage people to actually plan to attend, and in big numbers. We know that in this conference you'll have different audiences and participants, including policymakers, including researchers. So having people in attendance will enable us to engage with these stakeholders and ensure that questions are asked and answers provided from different people who in a way shape our research, our policies, and our practice in this country.
I would want to welcome everyone to come and join us in this special conference, which combines our 19th JASH conference, which is the Joint Annual Scientific and Health Conference, organized by the College of Health Sciences for the last 20 years. But in a special way, this year we have combined this conference, JASH conference, with the National Communicable and Non-Communicable Diseases Conference with the Ministry of Health. It is special in several ways that we focus on non-communicable diseases, which are rising in the country. Almost many people you find either they have diabetes, they have hypertension, a lot of cancer. So us to focus on these diseases is very important. Again, alongside not forgetting our communicable diseases, the TB and the HIV. It is also special in a way that we are celebrating 100 years of medical training in Uganda, which started here 100 years ago. And we need to highlight this, to look at what we have gained and focus on what we want to gain in the next 100 years. I want to invite all stakeholders in health. You could be a consumer of health, you could be doing business in health, you could be a provider of health or a manager of health. This conference will have something for everyone. For example, if you do business in health, there are opportunities to exhibit to frontline health workers directly so they can know what you do. If you're a policy maker, you're a development partner, you have a chance to interact with the different health professionals, interdisciplinary, one-on-one, during meetings, during breaks, coffees, and after the meetings, so you can understand where your program will look like. If you're a provider of health, you could learn new techniques, new way of doing things. And if you're a consumer of health, which is me and everyone, you could also learn about diseases, how to prevent them. But even if you already have the disease, you learn how to reduce the impact of the disease on you. I would want to call everyone, especially the College of Health Sciences students, lecturers, to come. For the students, we expect your energy, your enthusiasm, and to learn. for the seniors, we call upon you not to neglect this conference and put it down on your list. Please come and attend, guide the young ones in meetings, ask questions, such that we improve the quality of health science that we practice. I also want to call upon the policymakers to come and see how we can be able to translate the evidence that we have generated into impact. Basically, hold us accountable on the evidence that we generate. Is it relevant to you? I look forward to seeing all of you at the conference and engaging with you. Thank you.
This will be the new home of the School of Public Health at MakCHs University, the first institute of its kind in sub-Saharan Africa. For more than 70 years, the school has stood at the front lines of Africa's health, training generations of leaders who have fought HIV, Ebola, Marburg, and COVID-19. Their work has saved millions and shaped the future of public health across the continent. But today, our impact has outgrown our walls. We rent scattered spaces, stretching every resource to teach, to research, and to respond to the next crisis. That's why we are building a new purpose-designed home, a place for innovation, collaboration, and training of the next generation of public health leaders, because Africa's future depends on it. Right now, the continent has only 80 public health researchers per 1 million people, compared to a global average of 1,081. This shortfall threatens our collective health security. Every lecture room we build, every lab we equip, and every mind we train helps close this gap. The $10 million project is already halfway there, powered by, of course, the generosity of our staff, students, our partners like the Rockefeller Foundation, the US state government, NUFIC, plus, of course, many others. We invite you to join us in investing in the future where knowledge saves lives and where Africa stands strong on its own expertise. Because the future of Africa is its people, and their future depends on public health. MakCHs University School of Public Health, building the future of health in Africa.
First national conference on non-communicable diseases. It's a very good opportunity for us to publish and share our findings from the field in Mbale. We have some of the evidence which shows an improvement in the PLE results. So we are very excited about mental health. Mental health is very critical. You can see the impact on health, impact on people's lives, impact on the teachers' lives, and everybody around us. And really one of the main things that came out today was that we need to have all sectors involved in this particular issue. It is a multidisciplinary issue and we need everybody to be on board. So thank you so much for this opportunity.
I
have been working on child substance use within Mbale district, looking at the burden of substance use in facilities, looking at how facilities are ready to manage substance use problems among children and the broader population, but also examining where people seek help, where do people go if they have substance use problems. And then ultimately, I piloted a substance use screening tool that can help us quickly assess for child substance use to find out whether children are at risk for disorders of substance use. So what I found in my study was that 1 in 4 children that attend facilities, those who are aged between 6 to 17 years, had probable.
The global health community has made tremendous progress.
Influence change in this space or power these facilities so that they're giving the best care.
MakCHs has created an application that directly subsidizes care for these patients at these pharmacies. We've built a digital network, the first of its kind, across Kenya, Uganda, Tanzania, and Nigeria. We improve the quality and reduce cost of care in 2 ways. First, we reimburse pharmacies to follow clinical guidelines. And secondly, we subsidize care for patients paid for by global health funders.
So the beneficiaries here is both the pharmacist and the patient. The patient is going to get subsidized and quality care, the kind of care that they should be getting. And then the pharmacist is going to get the financial reimbursement.
The community can get tested and treated at a very low cost. MakCHs made us really improve at our facility. And in this area, nobody can die with malaria because we are here, unless that person has not come to our place.
And the results speak for themselves. We've seen a 4x increase in people following malaria clinical guidelines and similar increases in long-acting contraceptive uptake. And the best part is that we're able to use all that data to improve how the global health community responds to its challenges.
Without wasting a lot of time, led by Dr. Stavi.
Allow me to thank the team. HF Uganda Cares for creating
Without wasting a lot of time,
allow me to thank the team, HF.
This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions. This conference will be able to highlight the evidence, the research, the innovations, so that we can be able to see how do we address the burden from the aspect of health promotion, aspect of disease prevention, but also the aspect of curative services, but also at the same time be able to handle other emerging conditions.
We are closing in to the first ever national conference on communicable and non-communicable diseases, combining with Makerere University School of Public Health and College of Health Sciences. We feel excited as a ministry for this collaboration. First of all, we've been preaching the gospel of integration, and this conference is evidence of integration at hand, where you have communicable diseases and non-communicable diseases, stakeholders, and the academia coming together to deliberate about the ending of these communicable and non-communicable diseases. The diseases we are talking about are quite many, but of public health importance now as far as communicable diseases is concerned, we have HIV/AIDS. We have to end AIDS by 2030. We have to eliminate and end malaria by 2030. We have to end tuberculosis by 2030 and achieve zero leprosy status as a country. But also, we have quite a number of diseases that we have been doing well in terms of vaccination that we have to keep under control using the vaccination.
We have received over 400 abstracts. We expect about 500 guests for this conference, and this is a special one, uniting the Ministry of Health with the MakCHs University. And as the chair of this committee, I've been around and I've seen the importance of health communication, not only as a tool, but as a way of saving lives. At this conference, we expect to see how best we can translate science into information that impacts lives of people in their communities. I take this opportunity to invite you to this conference. Trust me, it will leave you a different person. I invite you, let's see you there, and ensure to register. The conference is up and running, and this year's theme is United Against Communicable and Non-Communicable Diseases. And believe me, we are going to make strides when we unite science with communication. Thank you.
This conference is such an exciting opportunity for us as the School of Public Health to be coordinating it on behalf of McChs University and especially jointly with the Ministry of Health because it comes at a time when the ministry has just initiated a framework for integrated service delivery. And for the first time, we're having a joint conference of communicable and non-communicable diseases coordinated by the Ministry of Health. And so it's an opportunity for us to pull this together and integrate even further, to work together with the ministry and deliver one conference that can cover most of the pressing issues that we have in health today.
McChs University has been organizing a joint annual scientific health conferences for 18 years now. And this 19th conference is unique because we have partnered with the Ministry of Health to have a concerted effort towards addressing challenges and issues that are affecting the health system, with a particular focus on communicable and non-communicable diseases. As a university, we are critical in research, and we hope that this conference will be instrumental in sharing evidence from our various studies, but also having other stakeholders, including policymakers, NGOs, communities, take part in the discussions, and this will also be instrumental in shaping our future research in health and in health systems. There are several ways one can take part in this conference. First of all, we can have an abstract submitted to present either oral or poster presentations. We can have entities, including departments, projects, and programs, submit to organize particular sessions. These could be workshops, these could be symposia or small events to disseminate findings and to generate discussions around topical issues. We also have an option of exhibiting people's work. It could be scientific products, it could be any other products that could be out there, whether from NGOs or companies. But most importantly, we encourage people to actually plan to attend, and in big numbers. We know that in this conference you'll have different audiences and participants, including policymakers, including researchers. So having people in attendance will enable us to engage with these stakeholders and ensure that questions are asked and answers provided from different people who in a way shape our research, our policies, and our practice in this country.
Good afternoon, ladies and gentlemen, or still good morning. Good morning. Kato, you can get us people back in the room and the ushers. Let's take our seats and we continue with the session. Our presenters are ready. So the ushering team, we request that you please man the doors and let the people come and take their seats. We kindly request you once again to be mindful of your properties and equipment, as much as we're also trying to make sure that we secure the place. But be careful and be mindful of your bags. As the people come in, we are going to have our second session for today. But in the meantime, I also request the people that are going to be presenting in the afternoon to make sure that your presentations are already with the Secretariat so that we save time on the loading. This session is going to be moderated by Dr. Raymond, and Dr. Raymond has already prepared the panel that is going to take us through this session that will usher us into the afternoon. And on that note, I would like to call upon Dr. Raymond Biaranga to come and step forward and tell us what we should expect, as well as inviting the session chair to come and take his seat, and we begin. Thank you.
Thank you very much, my chief moderator. All protocol observed, but I want to really appreciate our district leaders that are in this pre-conference. If you know you are a district leader, that is a LC5 chairpersons, please, I'm kindly requesting that you stand up and we recognize your being here this morning. Some of them were with us since yesterday. So our district leaders, current and future. Please, you be upstanding. We want to thank you very much for your enthusiasm. This shows that you really mind about the social infrastructure, the social well-being of our people. And I want to say that please continue that great work that you are doing in terms of monitoring the social services, but also facilitating our district health management teams to deliver. Do we have our chief administrative officers in the room? If you are a chief administrative officer, assistant chief administrative officer, town clerks, please. They stood up as the district leaders. Indeed, they are district leaders. So we want to also appreciate the technical arm of the local governments. Thank you very much for being around and supporting and facilitating our technical people. Do we have DHOs, district health officers in the room? Please, if you can stand up. We want to appreciate your time. These are the permanent secretaries and the commissioners at the district level. We want to thank you very much for the great work you are doing, despite the challenges. And we want to continue to commit that you are going to continue this great work that you are doing. You are not here by mistake, but we also know that because of the resource envelope, we could call a few. We had wanted all the DHOs to be here. That said, I do believe that the secretaries of health at the district level stood up with their bosses, the chairpersons. I also want to appreciate all the other members that are in the room. Thank you for making time. We are going to a very important presentation and then after discussion from yesterday, from the commissioner herself, the commissioner communicable diseases, mentioned integration, but also went on to explore what are the integration issues that we are looking at as a ministry, the direction that we are taking as a ministry. And we want to appreciate both commissioners, the one of communicable diseases and non-communicable diseases. Dr. Charles is here. We want to appreciate, already they are already doing the integration, not in mere words, but in action. This conference, if you read around it, it is National Annual Communicable and Non-Communicable Diseases, which shows already that we are going beyond just the words, but to make sure that we take care of the integration bit. So once again, this morning, up to lunch, from now up to lunch, we want to listen to our regional referral hospitals. We do believe those are the leaders in integration. We want to listen to how far they have gone. What are the issues that come out? What should we be looking forward to in the next 1 year, in the next 2 years? But also, how are they making sure that health services up to the grassroots, up to the health center one, up to the village, actually remain integrated? We should all remember that we are not here to treat diseases. We are here to treat people. The person is at the center of what we do. And therefore, having a person at the center who comes with tuberculosis, we don't want to make sure that he lives or she lives without knowing his or her HIV status, his or her diabetic status or glucose levels, hypertension, nutritional status, and making sure that he or she has all the information to keep him or her healthy. And that is what makes us wake up every morning, to make sure that we are looking at each and every person as an individual, not a disease. And for that, I would want now to call on the one who will be facilitating this discussion, Dr. Batibwe, the head of the executive consultants, to come and take on the podium and introduce the presenter and the discussants for us this morning. Dr. Batibwe is the Executive Secretary of none other than one of the biggest central regional hospitals, Mubende Regional Referral Hospitals. And we really want to appreciate his leadership in terms of working very closely with our health systems to see that the health services move on in an integrated way. I want now to pass it on to Doctor. Please take it on from now. And I kindly ask the audience, please be attentive and ask the questions, interrogate where the gaps are, and together in this room, all the brains that are here, we will make sure that we have a way forward in terms of how we are going to strengthen our health services going forward. So thank you very much. A round of applause to Dr. Emmanuel, please. Dr. Emmanuel, over to you. Thank you.
These things are not there anymore, and now the receiver is just here. So when you click, no, I'm not going to make any presentations. Okay, thank you very much. Yes, thank you. Thank you very much, Dr. Raymond. Thank you, the organizers of this National Annual Communicable Disease and Non-Communicable Disease Symposium. This is an annual scientific conference that we've been told before. We have been invited here as the senior executive consultants of regional referral hospitals to share our experience in the process of integration in the country. Like they've mentioned, I'm Dr. Emmanuel Batibwe. I'm the hospital senior executive consultant for Mubende Regional Referral Hospital. But also I was called upon to be the chair of all senior executive consultants and executive directors of referral hospitals of Uganda. We associate regularly to learn from each other best practices, to inform policy, to improve on service delivery. And one of the things we've been honing in much in the region of recent has been integration. So this morning now, we have a group of senior executive consultants from the regions who will join me right here now, the podium. And I'd like to first of all to call upon Dr. Ashbald Sebahire Bahizi, the SEC of Fort Portal Regional Referral Hospital, to come forward. He's going to share his presentation with us, and this will be discussed by a number of panelists who will be the other senior executive consultants. Welcome, Dr. Ashbald. I'd like to call upon Dr. Andrew Odur, who is the acting senior executive consultant for Lira Regional Referral Hospital, to come and step forward and be part of the panelists who are going to discuss further the integration. Dr. Andrew Odur, welcome. As he's coming, he'll be joined by Dr. Patrick Odongo, who is the SEC for Yumbe Regional Referral Hospital. Please welcome. And as he's also coming along, I'd like to invite Dr. Pande Legacy, the senior executive consultant of Moroto Regional Referral Hospital, to join us here as well on the stage. Please join us, Dr. Pande. The issue of integration is not new to all of you. All of you have been here, and I'd like to tell you, once upon a time, integration was the way of doing things in Uganda. Way before 1995, a clinician would sit in OPD and he attends to all patients in this single setting, attends to all diagnoses at the same time, and where he didn't have adequate knowledge, he would consult from a colleague or from the books which were there. They would even go back to the books which we used in medical school so as to have an up-to-date to approaching the care of this patient who was in front of him at that particular time. Then, were very integrated. Later along the way, we got disintegrated, especially on the emergence of AIDS, HIV on the scene in Uganda. Those who may recall, that's when we began having TASO putting up structures in the regional Pharaoh hospitals. At that time, there were still general hospitals. And already this process of disintegration started to give specialized attention to this onslaught of this epidemic of HIV, which was going on in the country. And then we got a lot of experiences, a lot of funds came in. The funding was adequate enough to put up structures within structures, departments within departments, all addressing HIV. They even had enough money to recruit the best of the best. You may recall the HIV program AIDS was being led by the topmost professors in medical school. You may recall. The power was there to even recruit direct from medical school students to come and participate in the researches which were taking place then. Then, as a medical officer, it was very lucrative to join these NGOs which were supporting HIV care in the country, to the chagrin of other disciplines in hospital care. You may recall that actually people became so well informed about HIV that now we even realize that they've forgotten about the mainstream care of other diseases in hospitals and health facilities. Until we were trumped, everybody was very comfortable where they were. There was a general flow from medical school to join these research projects. The whole medical officer is just picking data fresh from medical school in these projects. They went on to support these programs admirably. They were the guys who would travel the world, see places, were the ones who would be in conferences. And so the other remaining disciplines remained down, unattended to. They literally reversed in a way. And now to start doing some research and get funds, every discipline began incorporating an aspect of HIV/AIDS in them. They tried to open up chronic care clinics, the hypertension clinics, the DM clinics, and all the other clinics you knew. Even psychiatrists were adding HIV to the addendum to get some fund for their research. So much was it that even the engineers of roads, even those who are constructing buildings, they also say we care for HIV/AIDS. In their placards, you could see that information there. But now we have been brought back to the drawing board with the lack of fund. The funds were cut off. Those of you who were here yesterday, you heard the implementing partners and also now trying to look at the government for the first time for support. It has never been there. They always looked at the US government, USAID, and all the others. What we're also now looking at is a situation where we've got to retrain our health workers. So if we're to integrate, the principles will remain the same. We have to integrate the spaces, bring back the HIV clinics into mainstream medical special outpatient clinics. If there were admissions in some of these facilities, like my colleagues may share, you have to bring back these patients, put them together. The first people to disintegrate at some point were the people of TB, you may remember. They also got special funding under HIV/AIDS programs, began putting up TB wards. And eventually, of course, MDR TB came on, and so the disintegration continued. Those are still difficult to integrate back, probably, for obvious reasons. But now here where we have to integrate space, we have to integrate the health workers. There's been a call to pull the workers who are working for the HIV/AIDS projects into government of Uganda's payroll. The bureaucratic process is still daunting, but the will is there at some level. We hope it eventually takes place, that we have integration at that level. We still look forward to integration at the level of knowledge. We are calling back what we lost the other time, so that we are able to sit down and see the patient that comes in front of you without saying, you go to the art clinic, you go to the DM clinic, you go to the sickle cell clinic. We want to get that picture back. But this one calls for us to be trained, refreshed as well. And that one will be important for you. I'd like to welcome Dr. Andrew Odul to the stage. So we are in a situation where we have to integrate the pharmacies. We want to see that the pharmacy spaces, there was even a separate pharmacy for HIV/AIDS. Now I want to see them together, and this evidence we are going to look out for, is it being done? We are looking at a situation where the medicines are sharing the shelves, and they are also in the computerized systems, and they are all there. That will be a good way for us to go. We are looking at a situation where the duty rosters of the health workers is integrated in real sense. That you look at it as a manager, indeed, the names are all appearing there of GOE staff, COAG staff, USG staff. They're all there, and any other partners. We would like to look at a situation where the schedules for outreaches are joined. Once the specialists there from other disciplines, preferably maybe in a 14-seater wagon, they call them drones nowadays. I think they should give us those drones and we use them for these outreaches instead. So they can sit 14 or 10 staff for that matter, and that would be a very good way of integrating. We'll save on fuel, save on time, and of course the funds as well. We look forward to integrating the health information system. These are also different. EMR for HIV, clinic masters for GOU, EAFIA for GOU, and others. We want them all to be integrated into one. We want also to see the day when we shall be honest and we have an integrated budget. An integrated budget. So that we know how much the NGO, the partners are bringing in to chronic care, as well as how much GO is bringing in to chronic care. And that will be the ultimate, I think. We shall be able to monitor the progress, the implementation of these work plans together. And that will be true integration. So, ladies and gentlemen, those are just my few highlights. And I would like to now call upon Dr. Ashbal Bahizi to make his presentation. Thank you very much. You press any direction. Any direction.
Okay, I think it is still good. It is still morning. So good morning, everyone. Okay, so I've been introduced. Please, can I have the presentation? I work for Toro. So greetings from Toro region. Endamucho erugire 40 Toro. Muikare mutekane. So I want to share experience of integration of services in the Toro region. But importantly, this is a milestone from desk, office, now to practice. And this is what we are doing. I am very happy that most of the colleagues here have shared their experiences in the past about 1.5 months. And this is something which is going to be very continuous, and we want to have everybody on board. Okay, so I will rush through the background and progress, look at achievements, and then best practices and next steps. So where I come from, or where I work, that is the Toro sub-region, and the okay. Thank you, Michael. So we serve 10 local governments. That's 9 districts and 1 city, an estimated population of 3.5 million, and mainly agriculture. We border Congo, and of course, you know, we are also a hub of epidemic diseases. Congo recently, you know, Ebola, and then we had mpox. We had a lot of Crimean Congo hemorrhagic fever. So that is our facility, established in 1993. Bed capacity is 500 beds, and we have ICU, that is the intensive care unit of 4-bed capacity. Actually, now very operational. We've been operating on 1 functional bed, but I am happy that last week we functioned with all ventilators, and now we can handle 4 beds. And we're also almost ready for dialysis. So in Rwenzori, we shall also handle dialysis very soon, 6-bed capacity dialysis. And our staffing level is 23 as of today. But I know in the next about 6 months, we should be able to improve to 31 and also. We are supported by CDC, the Ministry of Health. This thing is not sensing your. So health infrastructure, that's where we are. We have 1 regional referral. We have 14 general hospitals, 6 are public, and 8 PNFPs. It is as you can read. Obviously, soon all health center force probably will become community hospitals, and therefore there's going to be improvement in the most aspects. The burden of disease I wanted to share as of 2024-2025 financial year, and focusing on HIV and NCDs. You can see what we have on HIV as the leading, then we have hypertension, followed by diabetes mellitus, but also on the side of mortality, you can see HIV is still leading in mortality, and then followed by hypertension, and then we have obviously poisoning, we have burns, but importantly we have diabetes coming up, and that is a worry for all of us. In this room, if we wanted to screen for non-communicable disease, beginning with even like body mass index, you realize that 1 in every 4 has a non-communicable disease. Okay, and that's something to worry. So we need to do great workup to, 1, for example, prevent non-communicable. It is our responsibility, and this is doable. Okay, and that is the HIV prevalence in the Toro region. You can see on the left-hand side, we have the prevalence hitting hard in the Fort Portal city, followed by the neighboring districts, Kabarore and Bunyangabo. But of course, most worrying is the recent. If you look at the percent recent infection, Kamwenge and Kasese is a great worry. So we don't know what has invaded the Kasese district. Of course, Kasese is now a very big town, very growing urban setting, and then Kamwenge, I don't know really. So if you come from Kamwenge and the Kasese, you need to be concerned about this, and we have shared this picture through our engagements, and then we have to prepare ourselves. So What are the key aspects of integration in our region? We basically operate the hub and spoke model. We also look at the vertical integration of services. We have worked on strengthening referral systems. We are in charge. And of course, yesterday, we had the engagement here with the heads of the different COEs. And I wanted to make a case that as a country, we have to deliberately make our referral hospitals the centers of excellence. So that now, if you're talking about integration, we would also be glad that the COEs integrate with us. So you come, we'll welcome you, okay? And we have areas of integration actually. Yeah? For example, for me, I would speak through number one, research. That's one area, which is very virgin probably in the referral hospitals. Number two would be grant writing. Okay. Number three, probably system strengthening. Okay. So that we make deliberately all our referral hospitals areas of what? Of COE. Then also I've done collaboration with partners and then working on sustainability of interventions. What is the progress so far under health facility based interventions? We were able to do capacity building in all the local governments. We have had structural changes. To me, actually, like beginning where I sit at the regional referral hospital, I can tell you that the integration started with the Fort Portal Regional Referral Hospital, because from a 2-bed capacity, a casualty unit, that is accident and emergency, when we did the integration, moving all chronic care clinics under one roof, HIV, tuberculosis, diabetes, sickle cell, etc. I was able to establish room. Now I have a 15-bed capacity accident and emergency. And then the noise is done. Because now you can't have a 2-bed capacity and you are handling how many highways? Fort Portal, Ntoroko, Bondiwudro, Fort Portal, Kasese, Bunyangabu, Fort Portal, Chendozo, Chegegwa, Fort Portal, Kamwenge, Kitagwenda, Mbarara, etc. So if you had, even if you only had 2 vehicle crash, you would expect an average of more than 20 casualties. So if you have 2-bed capacity, but now we can handle all of them. And that is really very good for us to integration. Then human resource reorganization, you will find that all referral hospitals at least have staff, government also handling the other aspects that were being manned by project staff. Okay, I worked in Chiwoga district and I was disturbed in the first 3 months that no government worker would actually attend to the HIV and tuberculosis clients. So all of them were actually project staff, and I told them, no, this cannot happen. So what I did, I said we integrate. So I would have on Monday by midday, I would expect a report from a records person employed by the IP, reporting on submitting a weekly report, and I would go to the facility to confirm whether he actually is the one who compiled it and then submitted it. And that's really what we need in integration. Under community-based interventions, we have held district stakeholders engagement meetings. Actually, these are actually barazas. Is there anybody from Rwenzori who is here? Very good. So they can tell us, if you get time, please, you need to tell us whether we have reached your district. But what I say, that for the 10 local governments, we have had engagements at district level, where all the DPCs, all the cows, chairperson of C5 or mayors, DHOs, all facility managers, civil society, and community representatives attend that engagement. The district health officer presents the general status, health status of the district, and then it becomes the background for what? For discussion. And important to say, how can we prevent the occurrence of disease? For example, why should people have malaria? Why should people have diarrhea? Why should people have gastrointestinal problems? Why should we have accidents? Okay? And also holding ourselves accountable. And I want to assure you that in the last 6 months, we have nearly traced ambulances on the road. I was telling my colleague that for the last 4 weeks, I have not had any referral from Rwenzori to Kampala or Mbarara. It is not there. So that means a saving on fuel, saving on vehicle maintenance, okay, and repairs, okay. And then now this stuff can do other what? Can do other work. But also that's also reducing people's expenditure, isn't it? So it means we are contributing, we are contributing on improving the economy amongst our people and in the country. We have had integrated community health outreaches. In the last quarter, we held in the Rwenzori under integration model, okay, community health camps in all the districts. And you know, I loved the feedback from the in-charges that, oh, even health center 3 can afford to support a health camp. We didn't use a lot of money. We used very, very little money. Okay, if I can tell you how much I spent in a district, I don't think it was any money beyond 1.6 million. But we did it. That even when we are traveling, we travel in integrated fashion. Okay? That I will move with my community health department officer, the biostatistician, the grants officer, because I need people to get their money before I move out of the room. And that's what we have done. These days when you tell mobile money, you tell, that one may not come. So I wanted to also be sure that when we are integrated, by the time we get out of the room, everything is what? Everything is completed. Okay? We have also done community mobilization. We have supported the pre-eclampsia and the eclampsia week by facilitating radio programs in all the districts, and we shall continue doing the same. So when we conducted assessment for integration, that is where we were at that time, July, September for the region. And you can see we're doing very well in the domain of health management information system, where we have the EFIA and the ALICE for the laboratory, and of course Uganda EMRS for the art clinic. Our request is that the ministry, I know is doing a lot, but to have these systems integrate also, so that we want to have one function system to help run our systems. Of course, we are not doing very well in the region. Some districts really in quality improvement. So that is under leadership and governance. We were able to hold the annual joint review, and we said integration. And I loved it in Rwenzori. We had, I think we had everybody represented: DHOs, cows, RDCs, DSOs, DHOs, cows were there, civil society, implementing partners, etc. But we said, let us also have non-communicable disease screening. So you can see the DHO Bunyangabo, the one who is writing is DHO Bunyangabo, and the one I think on the way scale is medical, is the executive consultant of I think Chegegwa Hospital. Okay, and you can notable that in that during that meeting, we had about 50 people with non-communicable diseases. 14 of them had very high blood pressure and had not known that they were actually hypertensive before. And also some of them had diabetes, undiagnosed diabetes with raised glycemic levels. Okay, and this is what means. So I am wondering why we came to talk about. I think Raymond, you may need to bring health workers so that they can maybe tomorrow, beginning tomorrow, get some people, blood pressure machine, weighing scale, height meter, okay? Start to also do NCD. Because I am very sure that people here who are sick and they do not know. You might be obese, you don't know. You might be hypertensive or diabetic and you don't know, okay? And that's what we call integration. Actually, for me, I feel bad when I attend any function, and then you do not give me opportunity to talk to the people, okay? And when I rise, I will talk about hand washing. You can see here, if you wanted to assess the level of hand washing before we take our meals, it is less than 1%. Yes, it's less than 1%. I was watching when they say break tea, lunch, everybody, it's like everybody gets online. And for me, that one, I have to be very open. We cannot speak integration and then we're not talking about hand washing, which is the basic, isn't it? That's the reason why you have a cold. That's why you have flu. That's why you have abdominal problems. That's why you have skin problems, isn't it? So please, today, I want to see hand washing. And of course, you see, we have also blindfolded the hotel managers that at the area where we eat, there are no wash facilities. You have to first go in the toilet, wash your hands, touch a door, and then go and pick a plate. Oh, God. So I think that also needs to change, isn't it? That one also needs to change, okay? Yes, thank you very much for, okay? Then under service delivery, I think engage district leadership to increase the scope of services like mental health. All the referral hospitals have a mental health unit. The districts, here I also, we are discussing that every district should have a mental health focal person. No, we don't want a focal person. We do not want focal person. We actually banned the issue of focal persons. We want a mental health officer per district. And therefore, if you have a district hospital, you have a health center 4, you have a health center 3, the new structure is very clear. At health center 3, there are 2 mental health officers. At health center 4, we have 5 mental health officers. At general hospital, we have more than what? We have more than 5. At regional referral, there are more than 10. Isn't it? So at least every district cannot miss 5 mental health personnel. These should be ready to work on us as health professionals, as to IPs, but also to general what? The general public. Okay, that's when it makes sense. So personally, I do not want to hear the focal person. No focal person. I want to hear mental health, mental health officers. Okay, so we have improved the linkage of clinical services to the community, and we have also identified spaces in the entire region for chronic care clinics. You can see in one of the fora, said Wenzori leaders recommended mandatory sickle cell screening before marriage. Because now someone was saying that we need to recruit more staff to manage sickle. No, sickle cell disease can be prevented, isn't it? If you're a carrier, you marry a normal person. If you have sickle cell disease already, marry a normal person. Then you produce carriers. If you're a carrier and you marry a normal person, okay, who is not a carrier, you will produce some normal maybe and carriers, isn't it? And if we can do this in the next 10 years, we can have a generation where sickle cell disease is not a problem. And this one, I am very happy that the religious, the political, I saw Honorable Wabuhinga, I think, has moved out. He was one of the champions of that one. Toro Kingdom has embraced it. Bwamba, and then the Obusinga Bwarwenzo Ruru. And that's the way to go. Involvement, that's also integration. Supply chain, one pharmacy serves all clients. And I think that is integration. You can say, we have shortage of staff because you want 10 dispensers and maybe 3 pharmacists. So now that we have crossed the 5 pharmacies into 1, do we still need all of them? Now we can prioritize a staff where there was shortage. Okay, And also we are doing integrated quantification and medicine orders. And of course, I've already spoken through EFIA. And health management information system, we have had all our health information assistants trained, including our interns, in the electronic medical records, the EFIA and the ALSYS. And of course, for me, I think I am the center for this, because I think March, April, I had about 180 staff transferred to my facility. And most of them, the other term, which I don't know how green is green, but I think did not have competence and skill in using electronic medical records. But I want to assure you that we are 100% paperless in my hospital. Okay, what we are only now working on is now to improve the quality of the electronic medical records. Okay, complete data entry, and then we also have capacity to do retrieval, okay, and then analyze, and also so we can inform what we can inform decisions. Okay. Under human resources for health, all referral hospitals have reallocated staff which were formerly working in independent departments to the OPD, rather in OPD to the chronic care clinics. And this is how you can imagine 9 referral hospitals staff were withdrawn following the presidential orders. So would we be still seeing patients? No. But at least we have not had so much cry in the last 1 month. Patients are being attended, and I think this is the way to go. Okay. And then we're also emphasizing on ongoing CPDs aligned to chronic care clinic. So we have held the capacity building training for almost all our facilities in the region, with the exception of the UPDF affiliated health facilities, which will be handled this month. Under laboratory systems and diagnostics, all laboratory requests are made through EFIA. There has been a problem in referral hospitals where EFIA ALS linkage is a problem. You'll find that the results are prepared in the ALS, and when they have to integrate, they are sent to EFIA for the clinician to view and make a decision. The relative indices are not reflected, and therefore you cannot know whether you actually have the right results or not. But I am very happy. I talked with Jamiru and his team, and this one is being handled everywhere. Under community systems and routine services, you can see that was, I think, we held a very big health camp for Portal City, like we have done in the entire region, and we're happy that we're able to see more than 12,000 clients in just a space of 14 days. And this is very encouraging to all of us. Then we also, under integration, support district activities. I don't know who took that photo when I was really talking, but of course, there are certain things I take very serious. For example, I think that's why I was talking about staff absenteeism. Some staff don't work, and then we have left them, and then we are paying them. Now, for me, if you don't, the Bible is very clear, and I know it should be also written in the Quran. If you don't eat, if you don't work, you don't eat, isn't it? When you go to Nari, they tell you for every meal you should work for 4 hours. So why should you pay a person who doesn't work at the end of the month? Okay. So there, I was actually feeling very sad, and I usually talk to my colleague accounting officers that if there are cases that they have feared to handle, they can send them to me, because I know how to handle them. Yes, and I believe we have cleaned what? We have cleaned our region. There's a district which was very naughty. This which were very, very naughty. And I love that the cow the chairperson LC5 and the RDC have actually called me. Others have come to office and says, yes, you have really helped us, and we shall continue. This one is not going to stop to be in Rwenzori. I know my seniors here are doing great, and we do not that we want to really have that the stick model, but we're also saying that you should not only give a carrot and then keep the stick, isn't it? The two should apply. Okay. And so we have supported the district activities. I think I've spoken through this, and then quality improvement. You can see the person who is coordinating. I think that is Dr. Kita, the district health officer, Bondibudro. For me, I integrated in Rwenzori. The one who heads the community health department is not a staff of the regional referral hospital. I said, if we are talking about integration, let us also integrate in responsibility and everything. So the one who heads the community health department of the regional referral hospital is the DHO, farthest about 90 kilometers away from Fort Portal. That's the Bundibudro. And that one works for us because peer-to-peer, now I can tell you I can enter every district without hesitation, okay? And I can tell you that if you ask the chairpersons LC5 and the DSOs and the RDCs in the Rwenzori region, they will tell you how they feel the regional referral hospitals. And this one, my colleagues are doing it, and we're going to make sure that we do it even much more and better to make sure that we feel each other. But remember, the starting point was making the referral hospitals the centers of excellence. And we cannot be centers of excellence when the lower facilities are not doing well, when the district are not doing well. It is our responsibility in this integration mode to have all of us do best things for ourselves, okay? And then others. So that is the client satisfaction feedback progress in the Toro region. Yes, not very well, but on track, and we expect that in the next, at the end of this quarter, we should be in green. We do not want to see any yellow or red. Okay, so opportunities. Now you'll forgive me because someone recently told me that we should not bury our heads in opportunities and leave problems and challenges to flourish. But for me, in my nomenclature, I don't have something called problem or challenge. I am not a problem generator. I am a solution giver. So I'm a solution provider. And that is what I want us to orient ourselves towards. You just say now, you see problems. You list like 20 problems, and then you list like two solutions. No. So me, I'm a no challenge man. I am a no problem man. I am a solution so all problems, I call them opportunities. All challenges, I call them opportunities. And of course, I know where I derive this from. Okay, is that I started with Yellow Star program. That was in 2002, 2004. Okay, Yellow Star program. I was posted. I can see my boss. I think the one who posted me, I think, is here, Mr. Nyakahuma Kao Kisoro. You can clap for him. That money brought me into public service. Okay, thank you very much, Kao Nyakahuma. So when I was posted to Bigodi, was a very bad facility where staff would tear books, registers, everything. So I said, now how do I start? And my transfer was cut from going to Gizi to Bigodi when I was in the middle of the journey. So when I reached there, I saw a box file with a yellow star. So I read it and had 6 indicators. I remember 6 indicators. Something about quality, something about client services, clinical services, health information, infection prevention, etc. So I said, okay, I allocated each indicator to a person, to an individual, and making sure that all of us become now managers of each other. I put a chart where I would put scores every 15 days. And at the end of 6 months, when it was time for appraisal, I asked everybody to make it to draw totals and make average. The best had 38%. In that facility, there were 2 people who had not been confirmed in public service after 5 years. So I went and asked the then personnel officer, you could remember Mr. Karietwa, and he says, no, those ones can be terminated. I told him, no. We are not going in that mode. We can find a way, okay? So I translated problems after listening to the community into opportunities. The opportunities formed the key outputs, and we had to formulate together the indicators and targets, and we moved on. I want to assure you that after one year, I was visited. That facility, that was Health Center 3. So you can know where I started from. Okay? That facility was visited by parliamentarians thrice. And I remember the words of then Mr. Nkata, who was our cow, says, no, it's about improvement in service delivery. You get it? And therefore, that's why I wanted to draw your attention to why I don't mention problems or challenges, and also to switch your mindset, okay, towards solution rather than problem. Okay. So now our opportunities, now we need to adjust medicine orders, and then also have two-way system installed for clinicians to have accounts for both our computers, but also the Ministry of Health systems. And of course, you know, this will help us in integrating all the electronic medical issues as Uganda EMR, the EFIA into one, so that we can speak through. At in our facilities, in our regional referral hospitals, for example, all of us are using EFIA at more than 95%. But when you do mortality surveillance, for example, it's not reflected in the DHIS2. And I know the ministry is working hard to make sure this one works, and it will be great for all of us. We want to lobby for more wage, and I think this financial year we have some wage for, even most districts have wage, okay? And I want to thank government, and they are very positive, and I think the president has spoken through. Next financial year, Minister of Finance may give us more wage to recruit staff, because there is something that we have not implemented, but for us we have started in Gwenzori, PDM, the first pillar, social services pillar, okay, in the parish development model. So now when I start talking about parish development, people keep wondering whether I'm going to work or not. But I'm a Ugandan, and I want that transformation. Eh? When they say the 10 growth strategy, I say, how can we improve? How can we do 10 growth strategy? etc. Okay, so we have to improve support supervision. We have to identify and train health facilities. We have to prioritize implementation of community differentiated service delivery model. So that what was happening in the HIV clinic also happens for diabetes, happens for high blood pressure, and everything. So that we can see that if you are stable, if you have glycemic control, I can give you metformin for next 3 or 6 months. If you have a stable blood pressure, I can give you medicines for 3 to 6 months. Okay, and I can even a person can even correct for you. Okay, that's what we want. That's what we want to implement. Okay, best practices. I think I've talked all through this. Okay, I've spoken all through this. Okay, so that is my. I think I can end here, but I think I can end here. Okay. Okay. Thank you very much.
Thank you very much, Dr. Bahizi, for taking us through your experience and progress in carrying out integrated services in Rwenzori region. I liked very much the broader outlook to integration from his presentation. Beyond what we've been talking about, he takes on innovations in different areas. He doesn't want focal persons for projects and programs, which is a good way of handling reintegration. He also has been able to talk about increasing in the scope of services, trying to strengthen referral systems, establishment of client appointments. They have been taking place in hypertension clinics, more in HIV clinics, but less in other clinics. Now he's adopting this across. And also even the differential service model, which is also there for us. And he also talked about something about repurposing PHC funds for integrated care. It's a very good innovation as well, which we should also adopt across.
Done.
And lastly, he prefers turning challenges into opportunities. Another
Done.
good approach to
Done.
integration. So thank you very much, Dr. Ashbald. And I would like at this point, before we receive questions, we have some more substitutionary presentations from their point of location currently to talk into the very same conversation which he has been having on integration. I would like to call upon Dr. Patrick from Yumbe to mention a few things additional to what Dr. Ashbald has talked about integration in regions. Thank you very much.
Thank you very much, Dr. Batibwe and Dr. Bahisi. My name is Dr. Patrick Odong. I'm the Senior Executive Consultant of Yumbe Regional Referral Hospital. Much of what I'll be saying has already been said by my colleague, but maybe I give you some more background of Yumbe Regional Referral Hospital. Yumbe Regional Referral Hospital is the second regional referral hospital in West Nile, and we oversee the districts of Yumbe, Koboko, Obongi, Moyo, and Adjumani. The population is about 2.4 million people, but of which 800,000 people are refugees from mainly the Republic of South Sudan and Congo. As per integration, we had training at the national level. After training at the national level, we had regional training of health workers who come from the region I have mentioned. And then these trainers then went at the district level and did training at the district level. After doing this training, then the health workers went into their facilities and started the integration process. And as a regional referral hospital, we were able to go and do support supervision to see to it that they are implementing what they have been trained about. Of course, the beginning was difficult because there was staffing levels. The staffs who were working under the project were stopped when there was that executive order from the President of the United States. But initially it was hard, but we were able to cope up. We were able to distribute our available staff to the different units, especially the NCD clinics, the HIV clinic, the diabetic clinic, so that services would follow. Now, the initial stage had a problem because these clinics used to run independently, but we were now bringing staff who never used to work into these departments. Take, for example, you're picking somebody from a ward and taking him or her to the NCD clinic. But with time, with the mentorship and training, they were able to cope up and carry out the clinics, the special clinics. Although as those facilities, those regional referral hospitals which were under the CDC project, we were very lucky that we got a waiver and some of our staffs were called back. But even though they came back, we continued to operate under the integrated model. We did not allow them to go back to operate the clinic how it used to be. And then for the operation to go on, we continue to do support supervision in an integrated manner. When the team is getting out to go from the regional referral hospital to the districts, because we supervise the general hospitals, the SATA4s, we go as a team, including clinicians, we include people from maternity, surgery, people who are moving from the lab, data, HIV clinic, and the like. We also carried out integrated outreaches, as it was talked by my colleague, because when we get out in the field, we go and see, we invite all the members from the community to come for services. The mothers come for antenatal, they come, they do the test for HIV, diabetes, they check for pressure, and also they give health education. As a part of outreaches and feedback program, we have also been carrying out community dialogues. For some people, they call it barazas. And it is very good because it gives us information about what the people feel about the services we are giving them. Also, part of the integration we do is that when we are going to radio, for radio talk shows, we take our whole team comprising of the different cadres of health workers. And finally, we are the annual JRM for our catchment area. And for that, we had it at Moyo district. Thank you very much.
Okay. Thank you for that submission and sharing of the experience from Yumbe on integration. I'd like at this opportunity, please keep your questions for the different panelists here. I'd like at this point to invite Dr. Andrew Odu from LIRA to briefly also highlight especially the unique areas of integration being carried out in that region. Welcome.
Thank you very much, Chair. Dr. Andrew Odu here from Lango sub-region, a region of 2.6 million people and increasing by day. Just yesterday in the paper, I saw a summary of HIV prevalence. And I was curious to note in my region, the city is about 9%. And if you look at most of the cities, I think the burden is increasing by day. This is something also to reflect on as we continue with integration. LIRA Regional Referral is implementing the integration just like the other regions. And when we had cessation of funding, I think our regional referral is among the heaviest facilities with very big numbers. We have 12,000, more than 12,000 clients in care. And this meant that we had a very huge number of staff under donor support. In fact, we had 157 staff under G2G support. So when this stopped, it was a big blow for us. But the spirit of integration, we were able to move this around, just like the other regional referrals have done in the shortest time possible. And this has been able to help us move forward. I wanted to just mention some of the fine-tuning that we've been able to do as a regional referral to properly integrate. One of them is that we had to go backwards and ask questions that how do we keep our eyes on the outcome of patients? It is very easy to say, okay, let's integrate. Are we seeing the patients? Everybody happy? But eventually the important question is, what is the suppression? What is the viral load suppression? What is vertical transmission that we are registering in the facility in amidst these challenges that we are all talking about? So as a regional referral, we instituted very regular performance review within the hospital to dig deep into the data that is coming through from the integration clinics to be sure that we are protecting the patients amidst all these other interventions. So I think this one worked for us very well, and we are continuing to do focus performance review meetings that looks at the different indicators of interests for proper planning within the facility. The other thing that we were happy to introduce is a wellness clinic. I think the commissioner was there a few weeks ago, and we have established a wellness clinic for the first time. And in this clinic, we are able to screen people who would be considered normal, really. We are encouraging that. Don't feel a headache, then you come. Don't feel, I feel weak today, let me visit the hospital. Come as you are from work, get some break, and then you come and we do your assessment. And we have been able to set this up within the region, and we have set up a unique lab for them to encourage them so that when they come, they're able to access the laboratory services, access the doctor, and these numbers we hope that can grow and tap the people who have not been able to be accessed easily if they were not sick. Of course, the other thing is the barazas have helped us a lot to filter through what are the challenges, what are the patients saying. Just 3 weeks ago, I had a visit by a representative of the people living with HIV in the region, and was very happy that he went through the clinic just to observe and make sure that the issues of privacy are handled, the issue of quality of care being offered to these patients is being observed. And this was very reassuring that a representative could speak to this and appreciate that there is a great effort being undertaken to ensure privacy issues are handled in our integration. Even when we have other patients who are not HIV patients attending to our clinics. Another thing that to strengthen the integration that we did in the region was to expedite absorption of previous donor-supported staff, and these are the G2G staff. We've been working very closely with the Health Service Commission, and I think for us as a Lira Regional Referral, we've been able to bring on board, I would say 80% of the staff that were previously affected. And this has helped us along the way to continue to fill the gaps that would have been really, really bad. We hope in the near future we should be able to close this absorption and have them onboarded on our public service. I think for now, those are the things I can add in addition to what has been supplemented by ours. Thank you very much.
Much appreciation for Dr. Andrew. You notice he also has very unique innovations, which I'm sure I've been taking note of as part of this whole integration process. Let's listen to Dr. Legacy Pande from Moroto.
Thank you very much. Yeah. In line with the theme of this conference, that is unified action against communicable and non-communicable diseases, I think the regional referral hospitals are poised to be a going concern for integration of comprehensive decentralized health services towards a human capital which is going to take us to the Vision 2040. We need to, for us as the Moroto Regional Referral Hospital, we do a whole system approach to integration, whereby we look at the health systems building blocks, the 6 health systems, WHO health systems building blocks, and we ensure that we integrate we ensure the principle of do no harm is withheld, whereby we assess, we review our processes in an integrated manner. Our process of as we do clinical care, ensure that we identify potential areas where harm could be, the near misses, and all those, and ensure that we stop gap, we prevent some of those. And most importantly, we cannot do integration without community engagement. So we take this one very seriously as part of engaging with the community to see what hurts them, what are their grievances, and they feel happy to be heard to contribute towards service delivery. We also do this in collaboration manner, where all partners, of course, we are in a space whereby most of the partners, the USG partners, most of them have stopped work, but we still work with those ones who are still existing, including CSOs who are still there. And of course, it is something that involves a lot of human resource for health development to ensure that they have the capacity enough to integrate, to view everything as they offer services in an integral manner, whereby, but we emphasize, just to add to what Dr. Bahizi mentioned, we emphasize not focalizing services. If we say we are going to get a focal person for integration, then we shall have lost the point. What we need is to have a human resource which is developed and it has the right capacity and mindset to offer integrated services. I'm called Dr. Pande Stephen. I'm the Senior Executive Consultant, Moroto Regional Forest, which is in northeastern Uganda, Karamoja. Thank you.
Yes, we had to wind up in the farmost part of the country. And thank you for sharing again your experiences. Clearly you can see that the regions are all applying the basic principles of integration as guided by the Minister of Health. But in addition, they also have very specific, unique innovations as they have been sharing with you. Moroto is building on the WHO health system building blocks. LIDA has been able to come up with a number of innovations as well, where they are mainly doing what he referred to as fine-tunings for integration. Yumbe shared also the experience from their point of view, and including also the areas of annual general review meetings, where they also bring together all the district leaders into an integrated meeting for handling this aspect. And Bahizi has also shown his areas which I've already alluded to. Now, ladies and gentlemen, we'd like to call upon and invite questions, specific and general comments for each of us here. Thank you. I can see very few hands up. I don't know what has happened. We have sent you sedated. Very few hands. Can the rapporteur help us speak these? Yes, the microphones, please.
It's near me.
We start from this side, clearing
It's
that way.
the microphone is near me, Chairperson. Thank you so much. My name is Robert Nachibumba.
I missed to see you standing. Where is that person?
Thank you. I'm here.
Oh, great.
I'm a member of the civil society, specifically TB. So, Chairperson, you speak with a lot of nostalgia about the old good days where a doctor could see a patient and manage all conditions under the same roof, which is very true. And then you also talk about the disintegration with the advent of HIV. I would like to say that this, what you call that disintegration, brought a very important aspect of looking at a patient other than the pathogen that old doctor used to look at. So many other factors that are affecting disease and progression, and at community level, at family level, and which was missed then. And it has come in, and that's the reason probably why today HIV, which has no cure, has been overtaken by TB, that has a vaccine for over 100 years, that has cure for over 50 years, but has now become the leading infectious disease. So my observation, my question to you is, how do you see that software aspect also being integrated in that management? That's to you. My question to Dr. Bahizi, and the last one, Chair, I shouldn't get worried. He speaks, and for me that is the best practice in public health. But my experience at national level, so structurally, the districts are supposed to report to regional referral hospitals. But functionally, the DHOs are like small gods there, and because they also have a line of reporting to the ministry directly. And so if you're not careful, and I learned that when I was, many years ago, I was a member of the country coordinating mechanism for Global Fund, and we wanted to see the best way possible of channeling resources to districts, whether you go through regional referral hospitals, which are on paper the supervisors, but functionally they are not, because DHOs are very powerful people. My question is, how have you been able to get that people who you don't directly supervise, who you don't sign checks for, to get working together like that, if it's not a unique leadership skill? In you, the way you speak, you seem to be a very unique leader. When actually, in reporting terms, the DHO can choose not to report to you and still get away with it. I would like you to observe that for me. Thank you so much.
Okay. Next one, please.
Thank you so much, Chair.
Please.
I am Kamara Daniel. I'm a nutritionist. My question goes to Dr. Dur from Rango Sub-Region. Thank you so much for the good work and for the initiative of the Wellness Clinic. And would like now to hear about the packages that you have in the Wellness Clinic and how have you integrated them? The fact that you're saying that you do not want already sick people, you're interested in persons who are healthy to come and do wellness checks. Which services are there and how have you tried to integrate them? I want to thank you. And hearing more about nutrition, how it is incorporated. Thank you so much.
Thank you.
Thank you very much.
I'm Matthias Mangeni from Namaingo. First of all, I want to thank all the presenters, but this goes to all of you. I'm happy that you have noted the issue of capacity building. I want to pick experiences from you. Currently, when we are doing facility-based mentorship, building capacity, facility-based interventions, you realize that to learn from you how strategically you are engaging the districts to be stimulated to deliver, as opposed to you going down and doing what some of the good things that you have been reflecting to us here. And then the other issue that I want to call, especially the Ministry of Health, is that for us in districts, the concept of strengthening the regional hub is very key. It's not always very nice for you as ministry to deploy teams to come to districts without notification and also involving the regional hubs. I want to pray that if you still have staff that do not have a lot to do at the ministry, we deploy them to regional hospitals, such that we can now have the real gist of strengthening the regional hospitals to answer to our needs and work together. Thank you very much.
Thank you very much. I'm called Connie Wheeler, JASH Otororo. I want to appreciate our executive consultants. That's good. I also want to say that as a district, as districts, but also as my district, on integration. And I want to also emphasize key benefits that we have realized with this integration. First of all, we have awakened up the clinicians who are only on HIV and only HIV. I think we have managed to integrate some of these skills across these clinicians, and they would even assume if it is a clinic, if it is not a clinic, then may not need to come and work. So I think that's a good one. And also another area we have also been supported to learn more about integration was through benchmarking. And I need to thank our partners, Baylor Foundation. You have helped us a lot on that. And what I need to say, amidst all this, we are also experiencing challenges which some of you have alluded, which is affecting us, especially at Health Center 3s. And we have also come to realize that actually the chronic care does not work effectively at the Health Center 3s. So at the Health Center 3s, we are realizing that the OPD model works best. But our biggest challenge is human resource. Regional hospitals, you sound like you are really very well positioned in terms of human resource. So it is affecting our integration at outreach posts. Because you look at the same people who are running the integration at the facility, you want to say to take the same group at the outreach. It is really affecting our services in that way. And our cry, this wage we are talking about, let it reach the district hospitals. It shouldn't only be in the regional hospitals, because we also need to integrate our services effectively. I need to appreciate, I think this wellness, somebody has commented, we need to hear more about this wellness clinic, because for us, the one we have in Tororo is actually a wellness center for the drivers, for those people whom we feel are lost and they need the first help, support to have their picks at the border point. In other facilities, how best, but still I feel we need to have adequate human resource. The other area which is a bit challenging is the issue of space. It is quite good. We are getting feedback. It is bringing down stigma to some extent. But issue of space, how have we done it? Some of these screens which we had abandoned, we are bringing them back. So privacy is very important to our clients because it's a cry. So that's how we are trying to manage that. And I love the 100% paperless. My hospital up to date has not been connected to AFIA, the digital system. We are still on papers, we are still struggling with the reporting tools because they don't exist. So the government, please, Ministry of Health, the HMIS division, we also need this digital system to our district so that we can improve on our data compilation reporting in the system. Thank you very much.
Okay, can we have the last two?
Thank you so
this
much.
round?
Good morning, ladies and gentlemen. Good afternoon, ladies and gentlemen. This is Dr. Mtunga. I'm from Chiruhura district. I'm the art coordinator for Rushere Community Hospital. And I'm glad that we're talking about integration. By the time I joined the hospital with support from Uganda Protestants Medical Bureau, Rushere Community Hospital had already started integration. I don't know whether they saw this moment, but funding was dwindling and partners decided to give it a shot. So we actually have early outcomes to share. If you can come tomorrow, I will be presenting an abstract on that. But I wanted to know, those of us who are doing integration, some are months into it, 5 months, 7 months. I would want to know how you're ensuring that there's privacy. I've also not heard a lot from private, not-for-profit organizations, hospitals, and how they are managing. Of course, one of the biggest issues is structures, but we have issues. So when you integrate general outpatient with chronic care, but you're not able to provide medications for all patients, then they are disappointed. So this is a cry to the Ministry of Health, the PHC that is supporting PNFPs and these other hospitals. We probably need to also look into NCDs and care for those patients, saying that if a patient comes through and is getting one package, then they're able to also get medications, because we have those who can't afford to buy the medication. Then I also wanted to find out, someone was talking about integrated outreaches. We have seen some challenges where someone says the outreach should be integrated, immunization, ANC, ART, TB. On paper, it looks easy, but when you're implementing integration of that kind, you probably want to follow up patients who interrupted treatment, those who are due for viral load and have not come in, those who need intensive adherence counseling and whose phone numbers can't be reached and you need to reach them. How do you integrate these services in one outreach? Because when you ask for funding for some of these outreaches, they tell you we are moving towards an integrated outreach model. But it's difficult because the patients are scattered all over and you want to do one integrated outreach. I'd want to know how best we can do this, if we can brainstorm on it, someone to maybe share a success story in their facility. Same as index client testing, it's difficult to integrate this with an outreach that is integrated. Like you want to go and do APN or SNS, but then you want to also do a targeted outreach. It is a bit difficult. So I don't know whether we are going to increase the number of outreaches, which points towards increasing resources, or there is a way other people are doing it in other places that they could share. But my biggest one also is on privacy. You're integrating HIV with general outpatient for health center 4s and some health center 3s and even some hospitals, because the chronic care is for bigger facilities. It seems to be bigger facilities, but down here, we are doing the integrated outpatient. So how is privacy being ensured? Are we identifying patients? In my facility, we give all patients who come in one card, but the outpatient is identified by a unique that is written on it. So if a clinician sees this patient, can be able to tell that this is an outpatient. And then in there, they have a hospital number, which can be reflected in EMR, which monitors their HIV activities. And then we can be able to identify the patient that way. But still, I still see some issues like if a patient who is on private basis is having a receipt of payment, the outpatient doesn't have a receipt of payment, definitely that raises a question. So if we are integrating this into general outpatient, how are we ensuring that no one can point a finger that the other one must be an HIV?
Let's first take the first round of questions and we respond to them, and if we shall take the second round. We would like to appreciate the questions, and maybe each of us will say where is referred to Dr. Odur. Omara Daniel wanted to know what packages are included in the wellness clinic when you are going about your integration. Just briefly, maybe you can answer that one.
Thank you very much, Kamara. Wellness clinic is 1 month old, I must state that. And the menu is basically, you have an interface with the clinician, and the normal biometric assessment and the vitals are taken at a point. The investigations are tailored. We have a organ tests that is on the first line of menu. When you come, we are able to do your lipid profile. If you're already a chronic disease patient, then you can benefit from additional tests. We are still piloting this for some time, and we see the kind of patients that will be coming into the clinic. But in the long run, we want to see how we have a wider space established for this category of, and we expand. But of course, nutrition assessment is part of that, where we are body mass, we take them a dietary plan. We have even a nutritionist who is a pattern clinic. They are able to access the general laboratory services within the hospital. The only difference is that we are trying to make it so that we encourage them to come. So when they come, we do not want them to be moving everywhere in the hospital. We have a dedicated team that moves their samples to the laboratory, results are brought, and then they're able to get their final consultation and plan with the healthcare provider. And add from that.
Thank you. Thank you, Andrew. Matthias wanted to know how we're engaging the districts to deliver as opposed to us going there. Dr. Bahiz had mentioned something to this, and I would like to request him again to briefly try to enlighten you how he has been doing it in the Rwenzori region, that he ended up having fewer referrals in this region. Dr. Bahiz, please.
Thank you, Doctor, for this moderation, and thank you for all the questions. leadership. If you ask me what in Uganda, number one, leadership and governance. Number two, leadership and governance. Three, leadership and governance. Number four and number five, leadership and governance. But to my brother, if you read 1 Samuel, chapter 3, verse 10, they say it is not what you do once in a while, but what you do consistently that builds a great destiny. So I'm a leadership governance expert in myself. I also don't know why I derive powers. So sometimes I tell people I don't understand myself. But and it is not that DHOs cannot report to regional referral hospitals. That's true. We constitute ourselves. Period. If you are ready to work with, they work with you. I was not central. When I was DHO, when I was DHO, I would I actually went to Mitiana to put order. I gave General Hospital in Czech on my way to end. But why can't you check on this hospital? When the hospital, I found everything was in a mess. For next, I went to new unit, went to theater, and we put to order. You get it? So it is. So leadership means. And that's what I say. These are very good people, but very constrained in the area. Funding they have in the district, the politicians are also. If you provide a good ground with the district officers, the chairpersons, chief administrators, and the security systems, you know that your cover for health, for education, for production, and all other departments is okay. So you can be a person. Look at each other as, because we are created in God's image, isn't it? So you do no harm. Maroto says do no harm. So that principle I think is very good. In the talk there was someone who says about attitude of doctors and specialists. That is also not true. It is about letting everybody involved. Koima ago, and I went to Soroti region and changed in 3 years that been among the 5 last facilities on the league table. Not even in the facility, but the district. And we say together is the beginning. Keeping it together is progress. And working together is success. And that means that is integration. When we are in this room, you can appreciate God was very good at integration. We have tall people, we have short, we have brown people, we have but all of us was a very good mathematician, very good architecture, and therefore it was what? It was integrated. The issue about resource mobilization vis-a-vis the budget where something. I am paid by Ghana a salary. This one I ran from Levi stand up. You know, my bosses, I can also make my bosses to study. Levi is a cow Burisa. You clap for him. Yeah. I'm not going to mention what all positive things that you can do for districts, hospitals, and health center force to get theater to use equipment and supplies. It was through his hand, and sometimes I look myself. That's like my brothers, and I even laugh because I went to the office of the DG then. That was the Honorable Minister Rusa. When she I grabbed it from the tray. I wanted to make sure it reaches national medical stores. I kept asking myself, if IP, that time Beta, IDI were buying cannulas, bupivacaine to use it. And I asked myself, if these people, if these IPs left today, how would we manage to provide safe anesthesia to patients? I wrote a letter and they signed it. And I moved it to national medical stores. And in less than 6 months, all districts were instructed to realign, to adjust the procurement plans. And we are very happy now in the country. We cannot cry for any IP that buy cannulas or bupivacaine. So it is about, if I have a functional vehicle and I have fuel, should it be a consultant to go and support a general hospital or a health center for? That's the model we want to implement. The good thing, we have been supported as 5 hospitals with some little funding to make sure that we support our lower level facilities. And therefore, the issue is not about funding. The issue is about tuning the mindset and also looking at ourselves as representatives of God to make sure that we cause change. I thank you.
Okay. Thank you, Dr. Bahizi. I want to respond to the first. It's true, I was nostalgic, just to remind you that actually what was done then can still be done now. Clinicians should be fully knowledgeable about total care of the individual. So this is where we are going towards. And indeed, I agree with you entirely that the disintegration brought in the championing of many of these aspects of approach to patient care, which are more holistic, more reached at the level of homes and the community level. And also, indeed, at that time, there used to be ladies used to be putting on blue. They used to be called health centers, I think. And together with the health centers, could go up to home level. And even follow-up patients. This was a bit of what was actually going on in a different way. So currently, we have to adopt so many nice best practices from the time when we had all this disintegration. Things like model, which is championed by this era, should be taken on in integration as part of our routine. That's one of the examples. And I also want just to hone in and say, integration is still possible in terms of outreaches. This is in response to Dr. Mutunga, who was wondering, how do you carry out integration? Isn't it just only on paper? One vehicle, one wagon, 10, 14-seater can take a number of cadres. What really makes it successful is if they are going in one region, one area, one district, one sub-county, for example. And each of these different people have a clear action plan of what they are going to target during the integrated outreach. Once they reach there, they disperse, carry out their work, and reconvene in the evening. And then they go back. That is the model we are taking on now currently. Like I said, saves fuel, saves time, but requires better integration, better scheduling, to decide when and where to go for which activities. I would like now to again key questions. Integration how are we ensuring privacy? How are we ensuring we handle the aspect of stigma? Is the other aspect of his question. Because the biggest challenges we've been having in the clinics currently as we integrate is people noticing that their members who are not of their type in terms of care. The HIV patients are worried of being seen going out with the large numbers of drugs compared to their counterparts. They are worried of being seen here. He's mentioned a good point. Mutunga mentioned that they are giving cards, but then one card has a very unique number. That's still promoting stigma. Because the moment people now read, the moment they start card, they say, this one, they will eventually learn. And realize this is a patient for, and then it will cause about stigma. So indeed, I agree with him. We have to find a solution to this aspect because it seems there's no way out of this. We are still being lumped together and we shall be lumped together in the outpatient clinic, in the chronic care clinics. And I think, I know it's going to take time that we shall eventually get used to it and let it be. And we stop holding down our hearts that someone is seeing me when actually is not even seeing you. Is there feeling pain? Is there pressure? Is high levels which probably have been talked to? And for you think is worrying about you who is also stable, maybe picking just your pills for refill. Maybe not. So it requires a counseling process. The counselors should learn to counsel everyone in unison, without talking to the different diagnoses separately. Putting them aside, giving them special days in the chronic tool, promoting stigma. And I think we have to talk to this more, this whole process of how to handle privacy and stigma. Does anybody have a success story to share to this key aspect, the key challenge in a we want a success story. Share a brief experience, please, and the microphone is given to you. We have 2 cases, 2 sharings. Please share the experience, successful story. Don't give us the other one again. The challenges, successfully.
Okay, Esther Nambala, Regional Quality Improvement Officer, Mbale Region, one of the regional pilot in the country. I will just share around the stigma. The challenge around the stigma in the dispensing point. Because coming on the same line. No one knows HIV, no one is around the dispenser. If I'm dispensing and I'm getting because the ARVs are in tins and the ARV tins. Most facilities in my region where we've done have done a lot of innovation around the dispenser, have created a special room where one person goes in at a point to be given the drugs without the rest of the patients seeing who is receiving what. We have a facility in the region that has even said the clients, most of the NCD client groups in the communities. And so as the team is going for outreach, the HIV team, the EPI team, they put in about 3 health workers that will attend to the NCD clients in the community. Some NCD clients have even formed client groups and are saving them money that they use to purchase drugs at a wholesale price, and these patients are really doing well. I know tomorrow we'll be sharing our abstracts and we'll share the outcomes of these patients. Thank you.
Okay, thank you very much, Doc. That's a good one. I think we can think of having a private room where we dispense medicine. So they go out with the handbags and nobody knows what is inside, probably. That's a good start. Another sharing, please, experience.
Yeah, thank you, Chair.
I am Dr. Sebuchinda Peter from Barara, the DO. Sharing issue of this is a big issue, integration. We have just created a new office, and this block, a large source of we did combine, you know, that area, so we combine the area at the window, so window. I think we need to do as a people yearning for integration. It has taken us decades to get where we are today. Have peer experts who will aim to you, Lord, before their languages. It took to train them, to give them the information. Now is time for us to go back and reconfigure the thinking and mindset of our people. This is what we lost 20, 30 years ago. Go back. And this is the information we must, especially comes to the point of waiting for a service. What you described earlier, Doctor, was very good, but they used to get a lot of waiting. It is to complain a lot about waiting time. Come on earth to tell them, look here, the road we are taking is that we are going to wait a little longer because we want to look at you holistically. We want to see everybody who comes to us in the same manner. The mission house is for us to deal with at 23%, rating at 30%, staffing, no, the waiting time longer. And if we're going to deal with that, now I'm speaking as a doctor, but also a manager. If we're going to deal with the waiting time, we must deal with the HRH issues. The song that we hear, or the problem that we're facing as DHOs, is the issue of wage. We want to see integration, the note of integration even at that level. If we don't do that, what we're talking about here is going to be a very nice tune of music. We must dance to. The other thing, you mentioned something very good about the dialogues, the community dialogues, and the barazas. From this, I want to tell, revisit these barazas and shift them away from politics. Because from experience, the current barazas are very political. They have become a platform of, you have understood. But now, you senior consultants on that platform, come up with an SOP for these barazas, so that for the sake of standardization, the baraza in Moroto should carry the same content with the baraza of Mbarara and the Kisoro to the country. So that when you say, in the last 6 months or 3 months, 48 barazas, the message should be standard across the board, not the political barazas that we have today. I think that would be helpful. When we do that, we will get there. Currently, this is the last point, Chair. We are now at the epitome of budgeting and planning. Many of you have seen the second slab. We are doing all these things. Even at this level, integration must be seen. Planning and budgeting, but with
an integrated mind, so that what translates from these budgets and work plans is integrated. If that doesn't happen at that level, at the level of the force and the hospitals, there will be integration, but it's not appearing in the work plan. It's not costed. That then we miss lots of at that level. So it will be layered at the operation level, at the health facilities, at the levels. That will be the issue of demo. Somebody said they are small gods. Small gods. Not. We are what we do and for the of Ugandans. I thank you.
Next round of applause. I think he has brought it out. He has stood firm and clear, right? So you are not demigods. But I liked very much his points, which brought about an SOP for barazas across the country, because currently barazas are being held down by many of these RDCs because in them as potential forms for political activity. Case mine were held down until further notice, and certain things are clarified. So clearly, I think we have to come up with that kind of documentation for them to appreciate what we are going to talk about, and we follow it through. And rightly so, also mentioned the thing about the work plan. I mentioned the work plan, exactly when, what, and who will do these activities which bring about integration. That was a very key message which you made, which I think is very, very important for us. So I think members, you've heard that already we are doing some form of integration. And we've also talked through the issues of stigma a little bit. I think it was one success. And we can continue talking about it. The large waiting space we have, or if it is one window, it has to be internal, but still bring about privacy. I encourage all members here to address this key monster of stigma. Let us be as innovative so that once we solve the system smoother for this. Thank you. The Peter, should we continue picking some few questions, or this is a okay? Please let me take it up to agree as.
Yes, Chair. It's okay. I see very, very important from the
rights
of care to can give us some so probably 3 hands.
Let me choose. This way we begin with the light blue. I meant that color. Then we move in the middle, another lady. Then here we have now the men have put up menu. Okay, let's begin those about, let us agree 4 questions. 1, 2, 3 here on this row, and then another one here.
I wish you would make them very short.
Thank you so much, Director. Mine is very short. Please, it is data-based. My name is the Regional TB Coordinator, South Uganda, based at MakCHs General Hospital. I want to appreciate all the presenters, but in specific, for Potro. Thank you so much, Dr. Bahizi. I was very interested in your data. I'm a data-focused person very fast. What I was able to pick are TB cases that were identified in 1 year, and you had identified 5,611 in a year, meaning that every quarter you're able to yield 1,402. The monthly basis, there are 403 cases with a mortality of 50 in a year, monthly 4 cases are dying in Fort Portal Regional Referral Hospital. My interest is your TB case notification. I really loved it. If I go back to my regional hospital, our regional hospital, at least in a quarter, we're able to identify 200 cases. But in Fort Portal, you're able to identify in a quarter 462. I really want to learn from you that magic bullet you're using to have this number of cases, and also how you're eliminating death among TB patients. Because having in a year, then 4 cases in a month, in a quarter, no, in a month is some good lesson for us to learn from. So that the TB cases we are finding, we save them from death. Again, we're able to find these more numbers that are in the community, then we treat them early. Thank you so much.
Thank you. Let's get down to the lady just here in the middle here.
Yes.
Yes.
Good afternoon, everyone. I'm Dusabe Anit. I've hijacked the microphone because it was passing through me. But I want to appreciate all the presenters, but the special thanks to Bahizi. And I wish this would come to the Kigezi region. The support you give to Fort Portal should also come down to Kigezi, where we are supported by Kabale Regional Referral, and their support is still lacking. To the organizers of this workshop, we have left some important diseases, the neglected tropical diseases, and also the geriatrics that also lead to the hypertension and diabetes. Thank you.
Okay.
Thank you very much, Mr. Moderator, and thank you.
Brief questions, please.
Yes. I just want to start with just a word of caution. We are integrating, but let us cease from comparative. It's like the boy child. The boy is failing because the girl. Can we identify on the other side that the boys need to be supported with? So the issue of integration and the stigma is coming right from that angle. We have seen, I'm Flavia Chomkam, I live with HIV and I access services. And I also coordinate the National Forum of People Living with HIV. The kind of stigma we are getting is both structural and practical. We have gone to clinics and we are told you thought you would be special. Now you are back here. We want to apologize. We didn't ask to be HIV positive. And we didn't ask anyone to create parallel structures, ladies and gentlemen. The crisis of HIV, which failed the government and world to manage, is the reason we had parallel structures. At the same time now, the crisis of no funding by governments and across the world Trump has done is the reason we are going back to the same structures. So some of the stigma is not really from us, but is also coming from the providers, from the leaders we are finding in these structures. So if I came for the first day and you are telling me you thought you are special, you now also have a TV, can I really think of even coming tomorrow? So let us integrate even in communication. And the missing link in this integration process is the lack of the user. As the recipients of care, we are merely receiving integration. We have not even been oriented, told these things have failed. Some people don't even know that medication is still there. The US had cut the money. So it goes without saying that because of stigma is because of the unknown, a fear of the unknown, a fear of and a lack of information is the reason we have stigma. I want to thank you, Dr. Bahizi. You said you are doing community outreaches. But I would implore that you do recipient community outreaches. You are carrying the entire hospital, the whole leadership down there. I don't know how many organizations and support groups of maybe cancer, of HIV, of TB, you are bringing to support in talking about integration. I appreciate integration because yesterday I shared, I have been through HIV, cancer, I've been through, I'm grappling with living with bone pains. But the way telling integration is like integration is HIV. Where is dental in those integration? It's not just about HIV, TB, and everything else. Integration should be integration. And we said, let us integrate, not to disintegrate. We have our community structures, particularly those of people living with HIV, which are formidable, immobile, static, and available for what is happening. We laid off community health workers. And we know that the VHT and CHOOS who are in place are not able to do the work we used to do. We have expert patients. Some have offered to start whenever they reach the facility, they are chased. We don't want to see you here. But they have been trained with the government loans, with the government donations, and they can provide the support, and they are continuing to support. We have done CSO mapping, and many people who have been getting money and coming to the communities have gone. But our PLHIV are the ones who are still picking people for family planning. Those who are abused, take them to the police. How do we utilize these structures to ensure that we integrate right from the community, to ensure that we have the right referral, the right linkages, the right psychosocial support? Right now, we are integrating mentors is still limited. How do we ensure that even for us who live with HIV, the emotional strain we have gone through all these months, when we've been told you've been enjoying HIV money, now it is gone. How do we ensure that we have integration, psychosocial support, to ensure that the stockouts that are happening, that we are facing and we think it is integration bringing it? How do you educate us to say, these things have changed? Go to the community. Facilitate me and in my district forums to go to the community to say, we are not being stigmatized or discriminated, but it's a change of operations. But I don't have resources to go and even talk about it. The district forums are all destabilized. How do we use those structures, Dr. Bahizi, to ensure that the district forums in your districts are able to go with you and speak from the voice of the community, the recipients of care? Because if I go and say, my colleagues will say, okay, I can now go to the clinic. And I'm glad you even said you are reporting increasing loss to follow up. Appointments are being missed. Why? Because we who would touch them, talk to them, and encourage them, we are no longer in the picture. And we know the VHT may not be able to do what we were doing, but we can support to refer, cancel, and refer. Let it be mutual, but not you used to, now you are. It's okay. We all suffer. Thank you so much. And I would like to, I'm not lamenting, I'm only saying the systems and structures of government are the ones which are causing the integration and disintegration. And if you really want the positive outcomes, include recipients of care in delivery of these services. Integration is mainly at policy and whatever, but when it comes to service delivery, it stops in the clinic. Can we go to the community and look at the recipient of care, educate them, and ensure they understand what this is all about? In us who are illiterate and poor and patient, we always understand very well, even more than those who are literate and who are professors. Look at adherence to treatment. It is us who don't know how to read who can adhere properly. Because you know this, the sun sets, the sun rises, the sun midday. But professors, you first even go to internet and you first check what the side effects, and you don't even adhere. Just to make it.
Okay, thank you very much, Chamokama. Thank you for that one. Let us make our submissions brief.
Thank you very much. I'll be so brief.
Yes.
I'm Dr. Anyonga Alfred, City Health Officer, Soroti City. I want to thank Dr. Bahizi for his presentation. Ready to hear about the city, how Dr. Bai or the regional referrals of Fort Portal is supporting Fort Portal City, aware that a few months back there was a reflection that Fort Portal City is on top in terms of HIV prevalence. I think now it has gone to 14%, followed by Soroti City, that now we're at 11%, and we're still leading in the country. I wanted to get from Dr. Bahizi if you have extended the hand, because from that time, Soroti City is grappling a lot, trying to work with the regional referral hospital. But the issues of HRH is the main factor to support us in that. And then I think all the cities, the 10 cities that are active currently, are still operating on the wage of the former health sub-districts, that were municipalities. I don't know if there is any city that is now operating like district. The budget is too small. I don't know if Ministry of Health or finance is able to support the cities as soon as possible to increase on the wage. We are really struggling a lot, and I think we would manage to address the issue of high HIV prevalence if we had our human resource improved. Implemented the integration training very well up to the end of October, when all the health facilities received that training, but it's still what you're saying, my colleague, the DHO, are the factors that are prevailing down. So through this, I'm extending our cries on behalf of the city health officer that cities need to be supported in terms of financing, so that also we address the issues of HRH and we bring down all these prevalences that are taking us very high. Thank you.
Yes, now I know what they mean by brief. Okay, let's try another case and see.
Yes, good afternoon once again, everyone. Once again, I'm Collins. And yeah, I have a few questions. Yes, I have a few questions. And solution-oriented person. So I have a few questions and some suggestions. Ideally, one suggestion towards stigma. To that, like I talked earlier, it seems no one is talking about biomedical engineering in this integration. And I have been really waiting for a long time to have directors of hospitals, the senior executive consultants in a room. It's hardly, it's really hard to just get one in their office to approach them and talk to them as a biomedical engineer or upcoming biomedical engineer, sort of. But having them in a room like this is really, it gives me so much happiness, and I can't leave without asking these questions. The first, you emphasize integration of health services across departments. How do you think medical engineering can be better integrated into these systems? The second, in your experience, where does biomedical engineering currently sit in decision-making for service delivery integration? Number three, with increased integration of communicable and non-communicable disease management, how prepared are the hospitals, departments of biomedical engineering well equipped to handle these rising complexities? Because we need to see these things get integrated into these health systems. Biomedical, we feel we are being really left out. Number four, from your perspective, what is the biggest human resource gap in biomedical engineering within referral hospitals and general hospitals in the districts? And how might collaboration with universities and training institutions really help? I am from Bara University of Science and Technology, and we have a lot of students there who are really so eager to get integrated into these hospitals, but they have no way. Number 6, if biomedical engineering were given a more prominent role in hospital integration, what key performance indicators would you really want to see from us? I don't know whether I skipped number 5. Yeah, I think I skipped number 5. As hospitals move toward digital health and integrated care models, how open are your institutions to adopting locally developed biomedical innovations? Because we have rising companies that are developing biomedical innovations and trying to incorporate them into these hospitals. How well equipped are you guys to, welcome all these innovations? My suggestion towards the battle of stigma, I believe this battle is looked at from, I can't say a wrong angle, but there is another angle we need to look at this. We are so much involved into, counseling people living with HIV and ignoring the ones that don't. Yet the ones that don't are the ones who are doing the stigmatization. I don't know whether that's the right word, but they are the ones doing the stigma. So the ones living with HIV are afraid of the ones who do not live with HIV, because they're like, okay, how are they going to see me get these drugs? But if you talk to the people who don't live with HIV, tell them, please don't stigmatize these guys. They did not choose this. This is not the way life is supposed to be. They're also human beings. Moreover, you cannot catch HIV when you sit next to them, when you give them a hug, when you do this work with them. Probably people's mindset will change and everyone will feel free to live in a comfortable environment getting these drugs. Thank you very much. My name is Collins Joshua Kabogoza, Mbara University of Science and Technology, Master of Science in Biomedical Engineering.
Thank you very much for that very nice short submission. Let me begin with you.
It was and you gave me a chance.
We give you a chance later.
Thank you.
Later.
It's okay, I honor you, Chair, Session Chair.
Yes, let's just keep you in view. Let's not lose you. Was that one person only? Okay, last one. That one. The last one is that one.
Thank you so
stop.
much.
Yes.
As a disciplined citizen, I had taken over that suggestion you did, but I think I have one ask here to the health workers and our SEC team. Is it okay to work together, move together, learn together with the community, the affected population you serve? That is my ask. And I will accompany it with only 2 scenarios here. When our Dr. Wahizo was speaking, I was very excited because when we are accelerating HIV in the Rwenzori region, that 1996 to 20 there, I was in the heroes of say Tagwenda and all those ends supporting the fishing which I serve. I wanted to know that in your mission, you not see much of the community. You mentioned all the local government, big men were there in your discussions. But lucky enough, the CSO came in last. How are you embracing the milestone we have moved? Because the community has contributed a lot in innovation, those shared service models, expert clients. We have learned together with a lot of innovation. That's why even you should go back to my ask and take it. We see how we can work together. Because bottom up, we have the issue of counseling, referrals, care and support. All that is the work of the community. Doctor not leave facilities, come and start following patients when we, the affected populations, we are there. How are you integrating the community arm with interventions which are very direct that this should be done by the community? We expect to have commodity supplies from you, the ARV, the PREF, and also testing kits, diagnostic services. That's where we need to track from facility to the community. But health is a two-way traffic. The community has a bigger arm and the facility has a arm. So when we work together, plan together, move together, we are going to have a very good service and the patient satisfaction center. My brother from Yumbi, last year I was doing some evaluation on transition. The government is taking it up that services must be got from health facilities which are government. So all the partners were almost closing by the time we did this evaluation. But I want to tell you the testimonies I found there. People not given support when they are referred, especially in Arua Hospital and Yumbe Hospital. People come, mainly there with their less support. Two, these are closing very early. By 2 p.m., somebody walks in, there's no health worker to work. There are many issues we need to work together and put right. Integration has come, but we are not going to move very fast and paint a picture that everything is okay. At the referral hospital, I know you have the best services, but when you go down in some of these districts, center two are delivering mothers, which they are not supposed to do. They are giving ARVs. You find a health worker handling the whole village of 15,000 people, 20,000 people. The issue of human resource is very key into all aspects. It's a long just jump up and say we are there. We still have to work together, learn together, and do a lot to improve. Thank you. I submit.
Okay, thank you very much we didn't know who that one was. We didn't name.
Okay, Simon Yevale is my name, and I'll mention two titles. I'm Executive Director of Fisher Folk Health and Development Initiative and board member of UNASO. UNASO coordinate HIV AIDS response for civil society in this country. Thank you.
Thank you for a very nice submission. Ladies and gentlemen, allow us to make some responses. Our key presenter for this panel was Dr. Bahizi, and he has a bulk of questions, but I'll still call upon his colleagues to submit any additions where they feel like. Yumba, you have some questions already, and each of us actually has have some questions. But for Collins, Mbarara, you are right, no one is talking about integrating biometric engineering because you're already integrated. You, unlike the peer staff we have, the lay testers and some counselors already on referral hospitals health worker structure. So you're already there. So you're already part of the hospital's decision making because you are a department of your own, headed by a medical engineer in the hospitals, at least in the regions. We therefore work with you in the preparedness of the hospitals in epidemics and other health systems care, given your very poignant position of being in charge of the functionality of the equipment and infrastructure and plants in hospitals. Cardinal role you have. You have even a special budget allocated to you by the Minister of Finance through the Minister of Health and Regional Referral Hospitals. The biggest gap in biomedical engineering is around innovativeness. Would love, and you also alluded to it somehow, where you should be having something unique and specific for you in Uganda, made in Uganda for Ugandan systems. You are still having a setup where you are importing and plugging and play into these systems and declaring most of our equipment obsolete. Yet ideally, you should be able to bring back to life these equipment which were hard earned using taxpayers' money. We have big loads of equipment because our biomeds have declared them obsolete. But if you bring another team of people around here, they can bring. So that one is for you in your training of these biomeds. When you bring them out, let them be innovative, original in a way, authentic. You know, they should stop copycatting, but they do their things locally. We want you to develop local systems for us, which can be useful for hospital systems. We have abandoned generators because you can't even maintain them. And you just spare parts and that. Why don't you mold those things here locally? We have power stabilizers which have been blown up because of poor systems, poor makeup. You should have made them better for us. We are now going digital and IT. That should also be part of you as biomeds. What is happening? They are laid out. We have oxygen plants which have been brought into the country. All of them have broken down. Why? The biomeds are watching. So you have a lot of work in this era of digitalization, and your key performance indicator will be proportion of plants and equipment fully functional. And also the state of repair of infrastructure of hospitals as another key performance indicator. That's my thinking. So at this point, I would like to invite Dr. Patrick Odongo from Yumbe to make a comment about what Simon I mentioned. That, and this also we've heard about in other referral hospitals, not only yours, where the referred clients are saying they are not attended to, hospitals may be closing early. I hope this is not recent, because if it's recent, I'll be a bit surprised. I hope it's a bit sometime back. Either way, we are still responsible. Over to you, Patrick.
Thank you very much, Chair, and thank you, Simon, for your observation. I think this issue came at the time when there was a directive from the Office of the Prime Minister that the health facilities which were being run by the implementing partner should turn over to the government of Uganda, and that is to the district local government. But I can assure you things have improved, and things are a little bit better. For the facilities closing early, that one I'll take it up with the district health officer. Luckily, I think he's also in the room. We shall get back and work on that. But he said that health center too is, pardon? Yeah, we had many facilities which were under in the refugee camps. They were within the settlements. But it is true, I accept that we do have a big gap in the human resource, and it was been said by the panelists here. We do call upon the government of Uganda to increase the wage bill so that we can recruit. Luckily, there are already a huge number of health workers who are in the population who need jobs. Thank you.
Okay, thank you very much. To our lovely sister Chomokama, we appreciate your submission. I listened to you yesterday as well, and I agree with you entirely. We have to integrate communication in all of these things. There's a big gap around communication. We have to have clear key messages to all parties concerned. I also liked another came in about the need for us to cancel, not only cancel people with diseases, hypertension, DM, HIV, cancer, and so forth. Let's cancel the health workers themselves, first of all. Let's also counsel the communities through our dialogues we have them in different fora about some of these things. Maybe we shall be able to temper down this whole aspect concerning stigma. And I agree with you entirely about bringing all other supports. There are disciplines that, we are all mainstream now. Cancer, dental, even the issues of stockouts are part of the system, which are not only affecting HIV sector, they also affect this other side. And we handle them all together. And indeed, you are right when we have to take up the volunteers. We are thinking about it seriously in this recent restructuring of the workers in USG and COAG. We want to take on in we are trying to initiate, we're discussing among us with my colleagues, how do we uphold some of these good practices without the personnel? These people who are below $200 were all laid off, and they are critical in that detailed follow-up of lost care, community outreaches, GBV, and all those things. So I think it was really critical. We said maybe we have to innovate around the guidelines we got from the government and try to see how we take them on a volunteer basis and we pay them locally in our local arrangements, but still fearful of auditors. We shall keep this in view. So thank you. I would like to request Bahizi of the questions I've forwarded to you, and the one was concerning about data and others which you've kept down. Please, Bahizi.
Thank you, Chair. And thank you for raising these questions and concerns about tuberculosis in the Rwenzori. To answer this question very well, first go to Chiboga district. Every district has a district TB and leprosy supervisor. I've made it mandatory that for all districts where we have health center for and general hospitals, we have responsible officers for tuberculosis and leprosy. So this one cascades to the lower level facilities to aid, number one, in sensitization, number two, screening, diagnosis, treatment, and the rest. But also importantly, that we track all our clients, whether in the hospital or outside the hospital, that even when they pass away, we have a clear mortality audit and we know the cause of death in a patient or client who suffered tuberculosis. And actually, tuberculosis being a big burden in the country is a failed responsibility by all of us. I don't think that we had ended the tuberculosis in very not areas in some districts, and I believe this is a model that we can use to end this enemy, tuberculosis. Tuberculosis, cough. I know there are other forms of tuberculosis, but if pulmonary tuberculosis is a problem, then we need to change mindset. And I want to believe that the mindset change is a mustard seed. And that's where all of us need to belong first. My sister, Tom Kama, mentioned something, but he says she gave us caution against comparative. And I want to believe that you have probably seen me in some fora talking about the supermarket model. If you have not heard, then you can hear it for the first time from me, physically. The supermarket model that we need to implement, the way all class know the services, receive the services, appreciate the services, and they go out and spread that you have clients coming in, clients moving out, and this can only happen when we work together. But of course, making communication a very, very important tool or weapon. City Health Officer Soroti, how have I supported the city? in many forms, but actually I attended even the budget conference. And during the budget conference, I asked them, the burden of HIV is high. I have not heard from any head of department, production, engineering, talk about the good thing the city clerk was available, and I guided during the conference that no approval of the budget, and the cows who are here, they know that there's what called cross-cutting issues. HIV is one of them, malaria, tuberculosis, gender, poverty. Those are cross-cutting issues, meaning that no budget ideally should be approved by any accounting officer when there is no inclusion of those areas. And obviously the city, this is a tourism city. I don't know what Soroti is, but this is a tourism city. So the HIV burden which is there is not only for the people living in the city, but they also what? They also come from outside. And then there was an issue of biomedical engineering. I think he has answered very well. Please, you need to come and learn from Fort Potro. I actually deliberately sent two engineers to Korea, but on a condition that when they come back, I don't hear any noise in the region, but also they must write two concepts to attract a grant where they went. And that's an assignment that you have to work on. Yes, you cannot, you must work for something, isn't it? But also change the situation, because the lives, we can make better lives us. It cannot be from outside. I want to thank you.
Thank you very much. Thank you very much, members, ladies and gentlemen, for listening to us. And I thank very much my colleagues here. My colleagues have been able to share with you the experiences of integration in their various areas of the country. But I think let's just take home one key point, that this whole process requires change management. Those 5 C's, those 7 R's, please read them up and apply them so that this whole process of integration takes on a good note via change management as leaders. Thank you very much for listening to us.
Thank you very much, our senior executive consultants. Once again, a round of applause for the team. These are only 5, but we have up to almost 16. So if they were all here, I think it would be a 2 days discussion. And there's a lot that we can learn from them. They are still around with us. Please engage them during the lunch break, and for the next 3 days during the conference, they will be available to provide more support. So thank you very much, Chair of the Senior Executive Consultants, and please continue the great work you're doing. I want to just add one more quick thing that we need to take home. Every time now he has talked about the change, the 5 C's, I would like to add one more thing. Mindset change. Where we are, where we want to go, if we can think the integration and first change our minds around it, I think we can make some great strides towards serving our people. And then lastly, we should all remember it's the person at the center of all the things that we do. So thank you. We are going for a lunch break. We are going for a lunch break. It's just it's 10 minutes to 2 p.m. Our next panel is ready, and we'll have this at exactly 20 minutes to 3. We are going to have our break just for 50 minutes, and 20 minutes to 3. Let's all be back so that we can start on the next discussion. Once again, thank you very much. Please, when you walk out, don't stand in the corridor. Go and discuss from the tables you're having lunch. Once again, thank you very much for being a very great audience, and have a very great lunch, and see you at 20 minutes to 3.
colleagues, take care of your variables.
I'm told, please take care of your variables. We have already confirmed one who has just been trying to carry out some luggage that is not his or hers. So please make sure you have all your belongings with you. Thank you.